Okay, good morning, everyone. Thank you for joining us for GHHI's 2021 Asthma Convening. It is my honor and privilege to turn this over to GHHI's President and CEO, Ruth Ann Norton, to get us started. Ruth Ann?
Good morning, and welcome to our asthma convening. It is an extraordinary turnout of really extraordinary and important people working to advance healthier housing and to improve the plight that asthma has impacted throughout the country. We want to first thank you very much for your partnership and for the wonderful endeavoring toward success that everyone has pulled together over the past year, working through the COVID-19 shutdown and remote work. And I think, as we'll see today, the amazing work that has been done with the EPA-funded project over the past 3 years, I think has brought many important lessons and many advancements as we as an organization work to advance the social determinants of health and racial equity through healthy housing. Daniela, if you'll take me to the next slide, that would be terrific. And I want to open by thanking our team, and which I'll talk about in a minute, as well as our partners here and the partner in this opening, Tracy Mitchell from the Environmental Protection Agency, for their wonderful support and alignment in this work. Today, we obviously are going to try to get to know each other a little bit more, hear from some of the best practices that we are advancing in our asthma work as an organization and with our cross-sector partners throughout the country. We're going to talk a lot about how building partner engagement across different sectors to advance healthier housing, and how do we look at and measure the impact on health and racial equity, on improvement of health and advancement of addressing the social determinants. And also we will focus on the M-Home National Work Group. One of the things that is critically important is establishing a uniform look at housing intervention so that we can build investment, we can understand what works, and we can better measure our value to families across America. And I think there has been just wonderful work done to advance the M-Home measurement tools. And lastly, we'll talk about what we're doing here, our virtual work and how that virtual work and through the toolkit that's been produced can be an augment, not only now to continue to advance work, but how it is an important tool as we return to a more normal work environment in this work and in home visiting and housing intervention, and how the virtual toolkit will actually help improve our effectiveness and efficiency. So I look forward to this meeting, and let's go to the next slide, please. So I'm Ruth Ann Norton, and I'm the President and CEO of the Green and Healthy Homes Initiative. I think I am the luckiest person in America to work here at this organization for the last 28 years, but also to be able to work with wonderful colleagues and partners as we do advance the work of healthy housing as bedrock to the improvement of health and opportunity for all Americans, and especially our work in low-income communities and Black and Brown communities across the country. We work to try and address those ill-conceived policies of the past and put them on a better track for the future that will allow us to return to having health at the core of our housing standards. We're going to be joined today by our partner and funder, Tracy Mitchell from the Environmental Protection Agency. And Tracy has, as I said, been a wonderful partner in this work. And I know we're just delighted to have EPA with us today and in the support through our grant program for the past 3 years. You want to go to the next slide? This is just a wonderful point of pride and privilege to work with this team as well as our entire organization. But the project team for the EPA asthma program has been led by Brendan Brown, who has been recently promoted to be our Director of Research, working with Michael McKnight, our Senior Vice President of National Programs, Annie Summers, who is our Director of Data Evaluation and Learning, and our entire social innovation and healthcare team, Daniela Chambers, whose voice you heard at the beginning, Kevin Chan, Kirsten Sweeney, and Trent Van Alphen, have worked with our 21 program sites through the EPA program, and you'll hear much about their work. But this team, along with the rest of our organization, is working on really important alignment of healthcare and healthcare finance investment to address social determinants through healthy housing, and has been part of groundbreaking work for several years at GHHI that we'll have a chance to talk about together. So I just want to take time to thank them for their great work on this program and many others that we are launching and advancing together. So as we look at the EPA-funded National Initiative for Asthma Reimbursement, we had three goals that we had tried to advance in the work. The first was business development and providing technical assistance, especially to programs who did not have a consistent asthma intervention program in the community, where there was not alignment between service providers who in the community are doing work that is improving indoor air quality and improving respiratory health, and their healthcare and health agency and government partners, and really building together on the business case and the work plans to advance and establish sustainable work in communities. We refined that also in a group of work around building the reimbursement mechanisms and contracts to actually create sustainable and aligned funding between health plans that are serving their Medicaid populations, and how there's providing reimbursement for services as we think about the elements that are needed to address asthma, being clinical, education, and environmental remediation. And we've especially focused on that continuum of care, as you'll see it. And the third part of our national initiative for asthma reimbursement has been to provide a more uniform base and platform for the intervention measures that we need to conduct for that environmental remediation to allow us to be able to measure these interventions that healthcare and those who are providing funding from the healthcare sector can rely on the work being done in the field, and how we measure outcomes metrics and the value add to improving health through housing. All of it for GHHI adds up to our work and our vision to advance health and racial equity through healthier housing in the United States. So let's go to the next slide. So as we think about the work and the work that we've laid out together, it is in this continuum of care, building in the clinic the necessary health responses to respiratory illnesses and asthma, and how we build that education in the clinic to the home, and building a base that is the connector to how we address environmental triggers, engaging residents and families and patients with the clinic to be able to address more holistically outcomes and improvements of outcomes on respiratory health. So we look at this as a comprehensive asthma intervention protocol that we've been building out. And that obviously goes in support of the elements of the CDC and NIH care guides around asthma. And we've been looking to fill the gap, obviously, on the funding for communities on how do you address outside of the clinic those elements of housing and housing intervention. And so the work has focused on how do we build that financial model. So as we've looked at the 21 site partners, it's broken down into 11 business development sites, where our professionals provided technical assistance to develop with these partners and implement comprehensive asthma home visiting programs that include the assessment of and control of environmental triggers in the home. To also, with 10 partners, some of which moved from business development to reimbursement, how do we build the actual reimbursement mechanism so that programs like ours in Baltimore, where we are very fortunate to have the support of AmeriGroup, reimbursing our work on housing interventions, that this can happen in Rhode Island with Integra, in San Antonio, in Contra Costa, and throughout the country, where we've been looking on how do we build this work. So that's happened through the reimbursement technical assistance. And then we had approximately 20 really just stellar professionals who helped us in the M-Home work group, where we convened and managed that environmental management health outcome metrics for evaluation M-Home, to recommend a set of standardized outcomes that we should be looking to measure on home visiting and environmental remediation for funders and for policymakers as we move this work forward. So let's go to the next slide. So we'd like to know who's with us today. We know that we had almost 400 individuals sign up for today's Zoom conference, some of whom will be watching the recording and some live. But we want to know how you see yourself in the role of the continuum of care for comprehensive asthma services. So Daniela, looks like we're building a lot of responses here, and you can let me know when we're going to end the polling and what we find out about who's with us today.
Yeah, we're getting a lot of great feedback already, Ruth Ann. It looks like right now we are about 24-25% on educators or community health workers, 26% on program managers. We've got policymakers who are here in the mix, a couple researchers, environmental assessors, and advocates. We're pretty spread out across the board. If you are new to the polling feature, it should pop up where you're able to select one of these options on your end. We'll give you just another minute. Oh, and it looks like we've got about 25% other. So we'd love to learn more about you and how we can connect to support your work in the field of asthma healthy home services too.
I have a suspicion that the others has a little bit of everything in their job, and it does take a village on anything to make it successful. But we're really delighted to see both individuals who are doing the work in homes, who are designing programs, making those programmatic decisions, and I hope part of the other is those who help to fund the work and look at how we build that. I know through our 21 sites, we've had very good diversity of participation from state health programs to Medicaid, managed care organizations, hospitals, as well as service providers and policymakers. So I think this is reflective. So I think we can, you keeping that, there you go. It looks like program managers went out, if that's the case. So let's hope that today will make the work you do much more effective. Do we want to go to the next slide? Great. And I still show the poll on my screen. I guess I have. There you go. So to give you a little reflection of who we are in terms of the partnerships that have joined us, as well as others throughout the country. This is the 21 sites in the national initiative that we've been working with. And you can see we have really good diversity, a lot up in the northeastern part of the United States where this is a big impact, but throughout the US. This is in addition to the almost 70 sites that GHHI works in other technical assistance areas. And so we have also brought that support work together in this work. And we're really appreciative of the partnership of everyone represented here. So we can go to the next slide. So I know in my own discussions with our team and what GHHI cares greatly about is what are our actual outcomes and impact. And I know that you share that with us in terms of the value that we are all bringing to the work and how we are improving our effectiveness and our efficiency in that. And if you can see here to tell us a little bit more about the partners in the national initiative, out of the 21 sites, 16 of the sites are implementing comprehensive asthma programs, and 13 are actively implementing the environmental management, measures management that includes the home assessment, education about triggers, and the interventions to remediate those triggers. There are about 423 families through this work who will be part of pilots that were started, especially in the programs where we're building out for the first time more comprehensive asthma work. 242 families have already been positively impacted and lifted through that pilot work. We will continue to report out the outcomes of the health outcomes and related outcomes on social determinants of health for these pilots, and work with the pilots to build to more permanent and sustained programs. We've also been able to raise $5.14 million for asthma services for the 21 sites, 1.24 for asthma services, and another 3.9 for leverage services, including the environmental remediation. And some have received new government funding, reimbursement from Medicaid managed care, support from hospitals. So we're continuing to look at that growing through this work and the examples that will get shared on an ongoing basis. And our reach on this, on the reimbursement reach, we've engaged 26 health plans across the 21 project sites, or across actually 17 of the project sites, to explore direct reimbursement through value-based purchasing, through administrative dollars, through cost savings, shared savings arrangements. We've engaged 7 state Medicaid offices to look at policy changes and advancements that can be made to focus on improving the health of housing as an important way to sustain this payment pathway and support the work in community of community service providers that are improving health. And we've educated through webinars and other educational venues approximately 1,200 individuals on best practices and reimbursement strategies. In the end, what we hope to always provide are the tools and examples of what is actually being done, what's being built, and the impact that it delivers. So let's go to the next piece here. So the M-Home National Work Group, part of my favorite part of this is building those metrics for this home visiting programs. So we have a publication we hope that you will download from this work group of national stakeholders, and really appreciate the work of Brendan Brown and Michael McKnight, Kirsten Sweeney, and others on our team who worked to put this publication together. I encourage you to go to our website and download that, where you will get offerings on input and guidance on how to measure. GHHI itself is clearly focused on measurements and outcomes, not only on health, but on equity, and we will continue to advance this work on how it is providing better health, but better opportunities through this work. So this is a tremendous work group that we have had participate. You'll hear from some of the folks today who've participated in this. I know we've got Susan Stepp from Le Bonheur, one of our great partners, on the agenda today, and many others. But we appreciate the fact that the work group included not only great thought partners and researchers, but implementers in the program. So from city government, state government, hospitals and managed care, and of course, our friends at the Environmental Protection Agency. So thank you for your work. We can't say enough about that. The other thing that we've developed over the past year and have been advancing with many of you to include in our work is how do we work virtually in this environment, and what do we take from our virtual work into the future. So we built a toolkit, and I appreciate the great work of our team in taking this charge up very early to help us not only in our direct service programs, but how we help you in building programs to respond to COVID, and then to take, as I said, the best practices forward. So we've built a toolkit that has operational protocols, best practices on how do we build data management and evaluation to know the effectiveness of our virtual work environments, and then other resources on how do we support that work. I've had a lot of discussion with our own teams providing direct services of where the virtual toolkit has actually improved and enhanced the educational sessions and the reporting from our clients on their conditions that they're facing, what they really need in support, and being able to build a stronger trust so that when we show up for work in the home visiting and intervention stages that are with some of us now and returning for many programs, we think we will have built a more effective way to start the intake and education process and relationship with clients. We hope you'll download the toolkit and let us know if you find it useful. Do you want to go to the next slide? Got another poll question. So Danielle, I'll turn it over to you. I think we're looking at which aspect of your asthma program is most important, do you feel, to the future success, and where might we help to add value in connecting you to resources and expertise?
And the poll should now be live on your screen, so feel free to share your feedback with us. We'll give it a minute here, then we'll summarize a little bit.
Absolutely no surprise to me that funding is the overwhelming answer of what we and precisely what we are trying to build is a sustainable pathway network of example contracts and tools as health plans themselves are looking at how do they advance equity measures in communities through better health, how do we address the social determinants through community service provision. I think everyone who has been in the clinic, who has served families, who is looking at health outcomes understands that we have to build a better pathway to addressing social determinants, and grant funding and contract funding here are at the top of these measures. We are big believers that if we can build reimbursement contracts and outcomes oriented value-based payment arrangements, that we will build a sustainable and stronger support element to the work we do in healthy housing, in addition to the grant funding from state, local governments, and philanthropy. So let's go to the next slide if we can. And this is my part to jump off. I'm actually sitting in those offices today that you see there. I'm happy to be back at work and back in the offices. This is my contact information and the contact information for our organization. I hope that you will reach out and let us know how GHHI can help to advance your work and to serve you as we continue to put these contracts in place for reimbursement. But my bigger pleasure of the moment is to turn this over to my partner and friend from the Environmental Protection Agency, Tracy Mitchell. Tracy, good to have you with us, and want to hear more from what's happening on the Indoor Environments Program. And thank you for your support.
Great, thank you. Can you hear me?
Yes.
Can you see me? Do I need to start my video? Okay. Hi, everyone. Thank you, Ruth Ann. Thank you for the introduction and for the great overview of this work. For the last 3 years, I've had the privilege of working with Ruth Ann, Mike, Brendan, along with the great staff at GHHI, as we've collaborated and partnered to improve public health and to promote reimbursement of preventative asthma strategies in some of the most vulnerable communities across the country. I'd like to thank GHHI for the commitment to this work. As you've heard, they do fabulous work throughout the country, and I'm so grateful for the opportunity to share and highlight our partnership, the partnership we've had for the last 3 years, specifically on this work. As you'll hear, I think I just want to highlight and kind of explain why EPA has a role in this work, and you'll hear the reason we partnered with GHHI as our commitment to public health and the environment. So you know EPA's mission, you may know, hopefully you know, EPA's mission is to support, yes, thank you, support public health and protect public health and the environment. Most people think of EPA's role as a regulatory agency that's enacting and enforcing laws to ensure we have clean water and clean air. Of course, that's an essential role of the agency, right? But just as important, a significant portion of EPA conducts research, develops guidance, conducts outreach and education on a variety of environmental issues and contaminants, and leverages partnerships with key stakeholders like GHHI on an international, national, state, and local level. Excuse me. The Indoor Environments Division, where I work, is a voluntary program, and the agency's lead on asthma. We work with partners and to leverage health, housing, school, and community systems to promote comprehensive asthma management, which includes environmental trigger management. So again, GHHI was a natural partner in this work. Next slide. Science informs policy and forms the foundation of EPA's program approaches. Science is very important at the agency, and there's strong evidence base in supporting national guidelines, as Ruthann discussed, that recognize the role of environmental triggers and their remediation as an important part of comprehensive asthma management. So I think everyone on the call knows that eliminating common indoor triggers like tobacco smoke, pet dander, molds, cockroach, and dust mites results in decreased asthma symptoms, asthma episodes, and improved outcomes for people with asthma. We also know that home visits are a critical component of care, particularly for at-risk populations. We also know home visits conducted by community health workers and other trained lay educators have shown to be cost-efficient and an effective way to provide these services. We all know home visits have been very challenging over this past year, and we've heard from many programs across the country that they've been able to successfully pivot to provide virtual services and virtual home visits. In fact, EPA hosted a webinar in January. I'll just make a plug for our webinar entitled Solutions for Managing In-Home Environmental Asthma Triggers During the Pandemic. This archived webinar is available on asthmacommunitynetwork.org. Hopefully you're all members of Asthma Community Network, but I'd encourage you to visit Asthma Community Network to find out more information about this webinar, which would be a great complement to the virtual toolkit that Ruthann discussed. Next slide, please. So as I said, the evidence base supporting the role of the environment and in-home visits was in place, is in place, and providers are seeing benefits to addressing the environment. Best practice examples are translating the evidence base into practice and policies, especially in at-risk populations. So one example of this is the Coordinated Federal Action Plan to reduce racial and ethnic asthma disparities. In this plan, federal agencies propose to build on the strengths and lessons learned from the past and existing federal asthma programs, combine efforts among the federal programs at the community level, and develop comprehensive strategies to fill gaps. This action plan presents a framework to maximize the use of our existing federal resources for addressing asthma as a public health challenge. So EPA, HUD, and CDC are the leads for the Asthma Disparities Work Group responsible for implementing this plan. And I'm very excited that later today, this afternoon, you will hear from my federal colleagues about our agency's individual and coordinated efforts to support this work across the country. Next slide, please. So as Ruth Ann mentioned, and as I've mentioned, partnerships across health, housing, and environmental sectors are essential in the success of delivering in-home asthma management. And so EPA has worked for years to identify best practices and successful programs like those who are with us today. And we're supporting the spread of the learning at the state and local level. So again, GHHI was a natural fit for and partner for this work. Through GHHI, we provided technical assistance, as you heard, and resources for community programs and health payers who are undertaking these efforts. And we have a variety of projects and partnerships that you can learn more about on asthmacommunitynetwork.org and at epa.gov. But this project with GHHI, again, is just one example of the technical assistance provided to systematically integrate in-home services across the healthcare and the healthcare system and get these services covered. As you'll hear from the programs that we worked with over the last 3 years, the 21 programs that Ruth Ann mentioned, there's no one perfect approach, no one perfect process, but GHHI was successful with their years of experience and expertise to provide customized technical assistance that met programs and communities where they are in this effort. So today we're here to thank them for their efforts, to learn from these programs, and to work to continue these efforts across the country. Next slide. In closing, before I turn it over for the bulk of the presentation, I'd just like to point folks again to asthmacommunitynetwork.org. You're going to hear from programs who benefited from the technical assistance, but there are many other resources available to you if you're working on sustainable financing of your in-home services. We developed what's called a microsite called Financing In-Home Asthma Care. And on that site, you'll find a wealth of information and resources, topics such as the value of asthma home visits, effective reimbursement strategies, and how to make your case to funders. So this complements GHHI's virtual toolkit and the work of GHHI, and I'd encourage you to join Asthma Community Network and to access what's available there. So in closing, I hope you find this information helpful. Again, I'd like to thank GHHI for their efforts to improve the quality of asthma care across the country. Thank you all for being here, because obviously if you're on today's webinar, you are concerned and you're working to improve asthma care in your community. And I'd like to thank you all for those efforts in these very trying times. Thanks again.
Thank you so much, Tracy. We're really happy to have you on with us this morning. I'm going to turn it over to Brendan Brown to lead us into our next conversation.
Great. Thank you. I'd like to thank Ruth Ann and Tracy for being very supportive and allowing me to be the project manager. I'd also like to thank our my colleagues that were the site leads and did a lot of the technical assistance for everyone, and also all the different partners that we got to work with around the country. I'd like to thank them at this point. But what I'm here to do really is to introduce, if we can go to the next slide too. Can you hear me? There you go.
Yeah, we can hear you.
So, okay, great. So I just wanted to make sure that we're going to go through some lessons from the field, and these are different sites that we worked with over the last 3 years. We'll be hearing from the BREATHE program down in East Baton Rouge, Louisiana, the Contra Costa Asthma Mitigation Pilot out here in California, as well as the CHAMP program in Milwaukee, Wisconsin, and then a program in partnership in Rhode Island between Integra and our site GHHI Rhode Island. Okay, next slide. Great, and so, and I'll give a quick bio before each presentation, but again, we'll kind of start from going clockwise from East Baton, or counterclockwise from East Baton Rouge, but we'll have Dr. Runa Bakshi speak about her BREATHE program. Michael Kent and Amir Thomas will talk about the Contra Costa Asthma Mitigation Pilot. They were both a business development and reimbursement site in consecutively, as well as we'll hear from another reimbursement site in this last year, the CHAMP program in Milwaukee, Wisconsin. We'll have Langston Burden tell us about all the great work there. And then we'll finish up with our partners in Rhode Island, Brady Dunkley and Margarita Robledo-Guedes, our outcome broker there in GHHI Rhode Island. I'd also, before we go to the next slide, I'd just like to thank the other participants in our this year. We had great partners down as part of the reimbursement support, the RBA Childhood Asthma Collaborative in Richmond, Virginia, as well as the DC Healthy Housing Collaborative in DC, San Antonio Kids Breathe, and the South Texas Asthma Coalition. Great programs and partners there, as well as in our business development cohort. We also had the Greater Capital Region as partners. So wanted to thank them. But we can go to the next slide, and I'm going to introduce our first speaker here. This is Dr. Runa Bakshi with a PhD in epigenetics. Dr. Bakshi joined the Louisiana Department of Health Section of Environmental Epidemiology and Toxicology in 2017. Her background in molecular underpinnings of environmental health informs her passionate work for promoting environmental health equity and elucidating the complex interaction between health, environment, and health. Runa currently leads the BREATHE Asthma Project at LDH, and she is supported currently by CDC-funded environmental public health tracking, as well as a grant from the Environmental Protection Agency, a state environmental justice cooperative. Okay, Runa.
Thank you, Brendan. Can everyone hear me?
Yep, you're good.
Awesome. Next slide, please. So I thank the GHHI team for inviting the Louisiana team to talk a little bit about our lessons from the field. This program was developed as a very cooperative endeavor between the Department of Health, Louisiana Center for Health Equity. We have LSU Health Sciences Center. We have a local hospital, Our Lady of the Lake Children's Hospital, and of course with technical assistance from Green and Healthy Homes Initiative. Next slide, please. And so just to give you a bit of a background on how we got started, a couple of years ago, we noticed that the western part of the county that I live and work in, it is an area where you would expect to see a lot of the likely suspects, if you will, that predicts worse asthma outcomes. And that's exactly what we found. This is an area that is high poverty, a lot of children in poverty, especially a lot of African Americans, housing issues, a lot of Medicaid usage. And it also had some of the highest levels of emergency department and hospitalizations for childhood asthma. So keeping this area in focus, we started our technical assistance in January 2020 with GHHI. Daniela, next slide, if you will. Thank you. And the way we developed the program, it's a very tiered service program. We start with virtual home visits at the moment, which at some point we expect to go in person post-COVID. And then tier 2 is where we bring in professionals to do a home assessment And then tier 3 is if they need professional home remediation. Not every client goes through all the tiers. For some, just that clinical and environmental education during the home visits is enough. For others, maybe they'll need a home assessment, but then the fixes can be done relatively easily, maybe some DIY, but then we recognize that for others, this would be more of a challenge and they will need more extensive home remediation services. Next slide, please. So I wanted to thank the GHHI team for doing a really, really thorough work of helping us develop an eligibility criteria, as well as program evaluation criteria that are based around ED usage, hospitalizations, but also interviews with patients regarding symptom frequency, severity, how often they use the rescue inhaler, are they on controller medication, as well as taking into account the home environmental triggers. And if we're curious for what our specific eligibility measures are and what we use to evaluate our program, I invite you to please take a look at our website. The link is right at the bottom of the slide, ldh.la.gov/breathe. Next slide. So our overarching goals for BREATHE was to kind of take a three-pronged approach to reduce the number of ED visits from the areas at risk. We have been more successful with some of these than others. If you would click, I want to say there's some animations that should come up, Daniela. There we go. Thank you very much. So our first triangle, that blue one that says creating dialogue about asthma management with communities at risk, that's probably the one that we were most successful with during our year-long TA with GHHI. We were able to apply and receive a competitive environmental justice grant from the EPA, which is currently funding virtual home visiting as a 2-year statewide pilot in areas with high social vulnerability and a high burden of asthma, but also COVID-19, because a lot of the measures where we found people were being disproportionately affected by COVID-19 was also true of asthma. Next slide. Thank you. And then this just kind of shows how our virtual home visiting pilot was built. We have an enrollment system, which we actually recently went to more of a referral by form on our website. So patients don't have to call in to enroll anymore. We also have referrals through our COVID-19 contact tracers, and we're trying to widen that referral reach through providers, FQHCs, local hospitals, urgent cares, and so on, excuse me. And then once our patients are enrolled, we take them through a clinical and environmental pre-screening. Everybody receives educational materials by mail or email. And again, if you go to our website, you'll be able to see some materials that we have recycled from other sources, others that we have created. And if participants are eligible for the virtual home visits, then they get 3 of them through the asthma team that incorporates a nurse, a respiratory therapist, and a community health worker at the Lady of the Lake Children's Hospital. If they don't qualify for it, we still give them a couple of asthma control tests, a phone check-in, and then take them through a final evaluation at the end of 3 months. Next slide. So our second triangle there, the orange one, improving indoor environmental quality and addressing housing needs. We are working with various partnerships to try to make this work. And then we're also working with Medicaid and the MCOs to explore home-based solutions. And if you click one more time, Daniela, I think there should be a little blurb that pops up, essentially showing that we are having ongoing conversations with MCOs. Next slide. And that's the part that's probably been the most challenging because our comprehensive pilot design is not a particularly cheap one, right? So that it comes with a $5,000 price tag, but I feel confident that if we can kind of find the right MCO and then target it to the right patient population, we might be able to be successful with this. Next slide, please. And that's my last one. Ultimately, we want to make an impact from breathe to try and improve the quality of life for children, all over Louisiana, not just in the county that we started this work in. And if you would like to contact me with any questions, comments, my email address is at the bottom of the slide. Thank you.
All right, thank you, Runa. That was great. And it's been a real pleasure. I'm a native of Louisiana, so it's been great working with Louisiana Department of Health, also with the Louisiana Center for Health Equity. Alma Stewart was a key community partner on that program, our project as well. Next up, we will be moving to California at another group or site that we worked with. The Contra Costa Health Services team. We had them as a business development in 2019, as well as they reapplied for reimbursement support the following year and was awarded through our competitive process. And it's been a real pleasure working with them. I'm going to introduce first, Michael Kent will speak first. He's the Hazardous Materials Ombudsman for Contra Costa County Hazardous Materials Program for the past 22 years. His job is to respond to questions and concerns about the activities of that program, to serve as a resource for environmental pollution issues for county residents. In addition, he staffs the county's Hazardous Materials Commission and advisory boards, the County Board of Supervisors. He also provides support to the Public Health Department on issues such as environmental justice, air pollution, and climate change, and represents the Health Department in Regional Health and Environmental Collaboratives. He is co-chair of the Bay Area Regional Health Inequity Initiatives Built Environment Committee. So Michael's going to speak first, but we also have Amira Thomas, who's from Contra Costa Health Plan, and was also played a key role. And her role is as a Quality Improvement Program Manager. She partners with federally qualified health centers and county health clinics and leadership to design and implement healthcare improvement initiatives. Her primary role for Contra Costa's asthma mitigation program has been co-designing the program workflows with our partners at AEA and the weatherization program, and developing partnerships with clinical teams. Centering equity as the North Star of improvement initiatives, Amira has used her role to focus on cultivating an equity lens while we were designing the program, and also exploring opportunities for member engagement and empowerment. So with that, I'm going to hand it over to Michael.
Great, thank you, Brendan. And can everybody hear me okay?
Yep, we can hear you.
Great. So it's been a real pleasure working with Brendan for the last couple of years, and great to see so many people on the program today, and appreciate the opportunity to talk about what we've been doing. So go ahead to the next slide, please. So our program is a deliberate partnership between our health plan and public health department and 3 weatherization programs in the county. And so at least in California, that partnership between weatherization programs and asthma trigger programs is kind of unique. And so I think that's what we bring to the table today. But it's the Contra Costa Health Services, both public health and the health plan. And then on the weatherization side, we have our county weatherization program, low-income weatherization program, the federally funded LIHEAP program, and then also through our county, it's called the BayREN program, which is a moderate income reimbursement program for multifamily and single family. And then MCE, which is the energy provider for most of the cities and county in Contra Costa County, is another partner. And then the Association for Energy Affordability, who is a nonprofit energy contractor for both the BayREN and MCE programs. Next slide.
Michael, can you hear us? I think you might be frozen. Give us 1 second, everyone. We'll try to get Michael back. If not, Amira, I don't know if you wanted to chime in while we're trying to reconnect.
I can. Yes. Can everyone hear me?
Yes, we can hear you. Thank you.
Okay. This while Michael. Oh, I think Michael's back. Michael, are you back? You're on mute.
Can people hear me now?
Yes.
No?
Mm-hmm.
Yes.
Thank you.
Sorry, my connection got dropped. So let me just continue. So Contra Costa County, for those that don't know, it's in the San Francisco Bay Area, just across the bay from San Francisco. Population of about 1 million, and racially very diverse. And in terms of poverty, pretty typical for for the Bay Area. Next slide, please. But we're not homogeneously diverse in terms of income and environmental outcomes. In California, the state government has developed an environmental justice scoring system for California called EnviroScreen, which looks at 20 different environmental factors and ranks different census tracts throughout the county. And those in the top 25%, they identify as disadvantaged communities. And you can see in Contra Costa, these orange areas along the shoreline of San Francisco Bay are the different disadvantaged areas in Contra Costa County, where we have 4 oil refineries, a number of power plants, and a number of chemical plants, as well as our freeways and rail lines. Next slide, please. And this is a slide of the asthma rates in Contra Costa County, the red being the higher rates. And you can see that our asthma rates line up pretty well with our disadvantaged communities in Contra Costa County. And so now I'm going to turn it over to Amira to continue.
Thank you, Michael. Just want to make sure everyone can hear me.
Yes, we can.
Okay, thank you. I'm going to focus a little bit more on the makeup of the program and how we've designed it thus far. This is a slide just from our Bay Area Regional Health Inequities Initiative, really thinking about the social determinants of health and how we focus this program to really address not just health behaviors with the education, but also really focusing on the living conditions and really focusing on targeting specific populations, as Michael Kent referenced in the previous slide, and also exploring our strategic partnerships. So on slides that we'll go over in a few minutes, our partnership with the Bay Area Air Management District, exploring those partnerships, as well as our weatherization programs, really being able to address risk factors within the homes. Next slide, please. So this is just an overview of the disparities within our county. And as you can see, there's a huge disparity between those that have public insurance versus not. So our Medicaid population for asthma ED rates is much more striking than those that are not on Medicaid. And specifically for African Americans in Contra Costa, it is even more striking. So this is who we're really targeting for this program. Next slide, please. So how we are our funding or our support, we have a Green and Healthy Homes Initiative technical assistance. This is not our funding right now. But we initially did a business plan with Green and Healthy Homes, and now as we are ramping up the program, we're really getting a lot of training and support for our community health worker and really exploring how our partnership with a health plan, which I represent, I am a program manager within the health plan, how we can use this as a business model to spread across the state of California. Next slide, please. So currently we are funded through mainly 2 grants. So we have a grant from the Department of Healthcare Services, which is actually being administered through an organization called the Sierra Health Foundation. And they are funding our pilot for 3 years, and we are expected to do 150 assessments through this, so 50 families over the next 3 years. And then we have also a grant from the Bay Area Quality Management District, which will help with funding our weatherization services. Next slide. Again, this is who our partners are. So really connecting the health department with energy efficiency programs. Our energy efficiency programs are really helping with the weatherization, contractors, that piece of it, while we are bringing the health component of it. And the education and clinical treatment piece of it. So just an overview of who we are. Contra Costa Health Plan is actually a county health plan, so we are county employees. We are within the public health system. So we are integrated within the hospital as well as some of our federally qualified health centers. And we service about 80% of the Medicaid population within the county. So we also are able to tap many of our members that are part of the target population. Next slide. So just the benefits of the weatherization services, reducing energy consumption, keeping the homes cooler. A lot of our, there are a lot of microclimates in the Bay Area, but our East County region tends to get really hot. And so also, benefits of weatherization is reducing energy costs and keeping particulate matter out of the home, and also keeping out moisture. Next slide, please. So this is an overview of our partners and also the services that they provide within the our overall operations. So the home visits are actually being conducted by a community health worker and a nurse. The nurse is being provided in kind from the health plan. And the grant funded the hiring of a community health worker. So the families will get 2 to 3 home visits. Currently, it is virtual, the same as Breeze, and also providing supplies. So whether it's a HEPA vacuum or mattress covers, so different things. And then also we have the home assessments, which are being done by our weatherization team and trigger remediation, and also our partnership with our energy efficiency programs as well to help with improving energy consumption within the home. Next slide, please. So this is a more detailed slide of how our program workflow currently stands, and so how we're getting referrals. We're getting referrals from primary care providers. That's a big referral source. Again, we benefit from being integrated within the county health system. Also, asthma ED, so it's more of a real time. We have a partnership with our Children's Hospital in Oakland, and also our county hospital. We're able to get real-time ED information so we can do outreach immediately. Also, our public health and our weatherization programs, if folks are being seen there first, they can be referred into the program as well. We have a partnership with an asthma allergy specialist in which they can do allergy testing and spirometry, and they'll also help with doing assessments like an asthma control test. And basically in our program, we do sort of a medical baseline, and then we provide the education. And then that also helps to tailor the education in the virtual visit, and also helps to focus on the environmental trigger assessment and developing of the scope of work for the home remediations. And then we do follow up for ensuring that knowledge improvement has taken place and that overall health outcomes has been achieved. Next slide. Okay, Michael, you can go ahead and jump in.
Yeah, so I'm just going to bring us to a close. So as Amira said, this is a 3-year pilot funded through the state with augmentation by the Bay Area Air Quality Management District, hoping to do 50 members a year. But like everyone else, we're looking forward to the future and ways to sustain our funding. The state grant was actually part of a statewide program to try 22 pilot sites in California to try to convince the legislature to make changes to Medicaid, what we call Medi-Cal here in California, to make it more sustainable way to get reimbursement. Working with RAMP, the Regional Asthma Management and Prevention Group, to try to work on statewide changes to the Medicaid program. California is going through a process called CalAIM, where they're looking at increasing in lieu of services to also maybe hopefully make these services more sustainable in the future. Beyond that, as we move forward and hopefully get better sustainable funding, we want to expand our program to be more like some of the other green and healthy homes programs around the country. And Marin County nearby is a model for us. And we've worked closely with them to learn about how they implement the Green and Healthy Homes program. And so we're hoping to be able to expand to do more comprehensive services, including spill and fall prevention, lead poisoning prevention, and other in-home work. And then also work beyond just the health plan to work with other health plans in the county and other community clinics. And so that's what we see for our future. Next slide. And then there's just, this is our contact information, myself and then Amira and Nicole Branning is our other manager in the health plan. So thank you very much, and sorry for the technical difficulties early on.
No worries, Michael. And thank you, Amira and Michael. We will go, I will just make a note to everyone. If you have any questions, you can put them in the chat. If you have them for a specific speaker, please kind of put the speaker's name there so we can try to direct it. We should have a little bit of time, 10 minutes at least, to do some questions at the end. Again, for Contra Costa County, I'd also like to thank our GHHI outcome broker there, Michelle Nakasaki, for really helping to bring some great partners to the table, as well as the Regional Asthma Management Program, the RAMP. And, you know, kind of this is a new program, so introducing to this program and learning from some of the other asthma home visiting programs in the region was really very, very helpful. So without further ado, let me take us to Milwaukee, Wisconsin, where we had in this third year, as part of the reimbursement support cohort, a great partnership there in Milwaukee, Wisconsin. And we will have Langston Verdon speaking. He is the program leader of strategic partnerships at Children's Health Alliance of Wisconsin. Langston is a program leader of strategic, or in his role, he builds partnerships to improve asthma management, enhance quality of life, and reduce disparities. He oversees the Wisconsin Asthma Coalition, a diverse group of 290 members spanning various professions statewide. Langston has over 17 years of experience in public health and population health, and is committed to creating environments where children and families thrive. He just recently received his Master's of Public Health in the last year from the University of Wisconsin-Milwaukee, with a focus on public health policy and administration. He's a father, and in his spare time, he enjoys staying active, from simple neighborhood walks with his 2 children to playing competitive kickball and paintball leagues, which I love. And Langston's also a great data and evaluation person, so I was very happy to get to work with him and the whole team in Wisconsin, and I'll hand it over to him now. Okay, Langston?
Hey, everyone. Like Brendan said, I'm Langston Verdeen with Children's Health Alliance of Wisconsin. First off, I just want to give a huge thanks and shout out to the team at GHHI who helped us this year with the technical assistance. It's not, you know, it wasn't an easy process, especially considering COVID. And, you know, a lot of our staff and our partners who are working with us were, you know, reallocated, obviously, to work on the COVID response for the state. And so we stuck it through. We had a slow start, but really ramped things up about halfway through. So it's really great. So thanks to the GHHI team for keeping us moving. Like Brendan mentioned, I manage the Wisconsin Asthma Coalition for Children's Health Alliance. I'm happy to announce we have 300 members now. We just hit our 300 member mark yesterday. So next slide, please. Basically, what I'm going to talk about is our process for building the case for reimbursement for comprehensive asthma services over the last year or so. Next slide. In Wisconsin, like most states, and like you heard today, asthma disproportionately burdens low-income communities and communities of color. In Wisconsin, the Wisconsin Department of Health Services implemented, probably about 5 years ago now, comprehensive in-home asthma services for children with uncontrolled asthma, which is very similar to the programs that the other panelists talked about. So I won't go into great detail. It's usually 2 or 3 home visits, followed by follow-up phone calls. They do the comprehensive education, asthma education, and assessment as well. Next slide, please. For this reimbursement sustainability project, our partners on this team were Children's Wisconsin's Community Health Management Program, Children's Community Health Plan, which is a Medicaid HMO in the state, the Wisconsin Department of Health Services Asthma Program, as well as 2 community weatherization and energy efficiency organizations, the Social Development Commission and Wisconsin Focus on Energy. Next slide, please. Primarily, we're going to talk about our process for building these partnerships, how we used our data and the results to encourage reimbursement, and ultimately our lessons learned. Next slide. So the first things first, and how we got to the point of partnering with CCHP, or Children's Community Health Plan, we had to think about which health management organizations would prioritize really innovative asthma services. It's going to be a project that, they're going to have to step outside of their comfort zone. So what we did first is we looked at the size of the payers in Wisconsin. Wisconsin, like many states, has multiple Medicaid managed care organizations. They vary in size, so we had to think about, of the proportion of their population based on size, how many members are likely to have asthma. And we use, your common statistics when you look at the percentage of your population with asthma to gauge which partner. CCHP has about 140,000 members in Wisconsin, so we estimated that about 10% of those would have asthma, maybe a little more, being that it's a Medicaid population, and about 5 to 10% of that would then have uncontrolled asthma. We also looked at where CCHP's their population is, and most of their population is in southeastern Wisconsin, where by and large, that's where we find the highest burdens of asthma in the state. We also took some time to think about, is asthma a priority for executives within the organization? If we're ultimately able to have a meeting, are they going to prioritize an asthma intervention? And lastly, could we even get a meeting with them? Luckily, because Children's, the CHAMP program and CCHP are both under the Children's Hospital umbrella, we are pretty confident that we would. Next slide, please. As it relates to data, one of the things that we learned is that there's good, better, and best, right? And so any pre-post data is going to be really important to have, looking at healthcare utilization, EUs, inpatient hospitalization, medication management, et cetera. Qualitative data like self-reports is great to have. It's going to be really important. What's even better is if you have some quantitative data. So if you have some Medicaid claims or the claims of that organization, it's going to get you even further. In best case, if you have a control and treatment comparison group, you're likely to get some movement from that health plan. Next slide. Just a quick reality check. Self-report data is great, but it might only just get you into a meeting. That's actually the quantitative data is really needed to seal the deal. You need some hard evidence from that health plan or from the state, DHS or Medicaid, to really prove that this program is beneficial. In addition, it's important to find a way to connect the outcomes that you find in your data to your partner's mission and values. And so if they really focus on health equity, if they're focusing on asthma, if they focus on pediatric populations, make sure you connect your outcomes that you're sharing with that team to their mission and values. Next slide. So for our reimbursement study, we use retrospective controlled pre-post evaluation using a difference in difference analysis of Wisconsin Medicaid claims. Long story short, I had a ton of conversations with Medicaid pre-pandemic. They granted us access to their data. We were assigned some data analysts as a part of this process, and we're able to do a difference in difference analysis, which is really is looking for what's the treatment effect, how much of the asthma care programs can be attributed to the improvement versus the control. Next slide. And what we found is that the asthma care program, when we adjusted for confounders and limited our analysis to 5 to 17-year-olds, was attributed to a 35.5% reduction in asthma-related ED visits, a 35.7% reduction in the probability of having 2 or more ED visits, an 8% increase in the count of asthma medications, and really important, a 35% reduction in all-purpose inpatient hospitalizations, and a 37.7% reduction in length of stay across the board. And so I highlighted those last two because as I had conversations early on with health plans, being that the asthma population is small, they really were concerned with how does this influence the overall health and well-being. Next slide. So our lessons learned through this process is make sure all the partners on the team have the same why. We want to improve asthma health and well-being for kids in Wisconsin. Leverage your data. People are going to doubt it along the way. You know, maybe this worked in other states, not going to work here. We have the data to prove that it does. Scope creep is always an issue. Maybe we should add these services. Maybe we should focus on these other populations. Stay true to your data. Have a clear communications plan throughout the process. You know, how are you going to communicate via email? Is it a Microsoft Teams approach, whatever it might be? Next slide. I'm sorry, I'm trying to wrap up so we have some time for questions. Keep the momentum going and share successes. It was really challenging this year because of COVID, so every small success, we really had to celebrate it. We have some challenges and barriers with our partners maybe being unresponsive early on, missing meetings, and so we really had to push them to show up and leverage, you know, again, the data. We know this works. This is the closest we've ever been to a reimbursement solution in Wisconsin. Let's keep the momentum going. One of the challenges that we had is that our executive sponsors weren't always kept in the loop by our partners. And so each time we would meet with them, we'd have to spend a great deal of time providing some background information. So a lesson learned from our challenges is to really keep your sponsors in the know throughout the process so you don't have to have some of those challenges that we had. And lastly, don't put your eggs in one basket. While we're having these conversations with Children's Community Health Plan, we're still having conversations with Wisconsin Medicaid to provide fee-for-service for these programs through different funding platforms. And so, you know, one way or another, we're going to get this reimbursed in Wisconsin. Next slide. And that's it. I did it, Daniela. Got it done in 10 minutes. So please reach out if you have more questions at elverdeen@chw.org, and I'd be happy to chat some more. Thanks.
Yeah, great work. Thanks, Langston. And we'll move quickly here to the next group. We have Brady Dunkley. He works with Integra, an accountable care organization based in Providence, Rhode Island. Brady's work with Integra focuses on developing partnerships with community-based organizations to address health-related social needs and address upstream causes of ill health, while facilitating the integration of social determinants of health into primary care. He has led the design and implementation of Integra's asthma program, ARISE. He'll talk about that, and its related pilot partnership with GHHI Rhode Island. Before joining the public health field, Brady worked in nonprofits in Rhode Island and Nicaragua. He has particular interest in supporting the community health worker workforce, particularly now in light of the inequities revealed and deepened by the pandemic. He appreciates the old CHW proverb, time is medicine. He'll also be joined by my colleague, esteemed colleague, Margarita Robledo Geddes. She is our Rhode Island outcome broker for Green and Healthy Homes Initiative. In her role, she is responsible for coordinating multiple federal, state, and philanthropic resources and working with state and local municipalities, partners, and nonprofits to develop programming that provides low-income Rhode Island residents with integrated energy efficiency, health, and safety housing program services. So thank you all. I'll also let everyone know that after this, put questions in the chat. We'll try to do a couple questions. And then after this session, we'll be going to a break for 15 minutes. And then we will have another great session called Strategies for Pursuing Medicaid Funding for Home-Based Asthma Services. So Brady, do you want to?
Yeah, thank you. I'm excited to be here in such good company. We're delighted at the work we've been able to do with GHHI and more broadly around the social determinants of health. Integra Community Care Network is an accountable care organization, or ACO, in Rhode Island that represents 2 hospital systems and an independent provider association. So those are Care New England, South County Health, and Rhode Island Primary Care Physicians Corporation. As an ACO, that means that if you get your primary care from one of those providers and you have health insurance through one of the organizations that we contract with, then we're accountable for your health, for your total cost of care, and the quality of your care. All told, that's about 150,000 Rhode Islanders, of whom 50,000 are Medicaid. And the map, you see it right, is a map of our Medicaid accountable entity population. I was noticing the Contra Costa presentation with Michael and Amira and the map of the county there, and noticed that the population of Contra Costa is about the same as the population of Rhode Island. So small but mighty state. And essentially every heat map that you develop for Rhode Island health measures looks like much like what you see in front of you, which is a concentration of poverty in the urban cores, related health disparities that are highly stratified by race and ethnicity. And I didn't pull asthma data in particular for this presentation, but you could superimpose a very similar asthma presentation, asthma population map, and it would look very similar to what you see here. Next slide, please. So I think that healthcare is increasingly understanding that if you want to make a meaningful difference in health at a population level, you have to address the social determinants of health. And if you want to address the social determinants of health, you have to go upstream, and you have to work in partnership with community-based organizations that are doing that work. And you have to act as an ecosystem player and not only as a sort of customer and vendor relationship. We have applied those lessons and those principles to our thinking about social determinants of health strategy around respiratory health, and particularly within our Medicaid accountable entity, which is the newest of the 3 lines of business we have. And we've been, over the past year or so, really developing pilot programs to begin to work on SDOH and work on respiratory health and disparities. I'll highlight the 2 today, of which GHHI has had a hand in. One is the ARISE asthma program, which in a moment I'll talk about in detail. And one is the I-SPY, or for Integra Social Partnership Innovation Initiative program, which put out to RFP in the community to community-based organizations the question, what can you do about what do you think you can do about the social determinants of health? We received a number of proposals. It was a competitive process, and we established 4 partnerships to test and pilot. And we've just concluded that and are moving into thinking about how to scale. So those are the 2 sort of linked initiatives around both SDOH and asthma and respiratory health disparities, currently moving from pilot to scale. So the next slide, please. So ARISE, every asthma program needs a clever acronym. Ours is Asthma Response Integrated Supports and Education. And it built on evidence-based program that's been in existence for quite a while in Rhode Island called HARP, the Home Asthma Response Program. One of the 2 sites for that program is St. Joseph's Health Center here in Providence, which has a history of doing a home visiting and supplies program, very, very similar to what you've heard in the other presentations. Eligibility previously meant that to get into HARP, you needed to have 2 emergency department visits or 1 inpatient visit. We decided to open that up to pediatrician referral instead, with the idea that we want to prevent ED visits and hospital utilization and not only be reactive. So if a pediatrician in our network has the assessment that a child has uncontrolled asthma and the family could benefit from these home visiting services, we open it up to referral. So that's this 3-visit series. The second visit, there's a delivery of supplies like the HEPA vacuum and the hypoallergenic sheets, integrated pest management supplies, intensive education. But in addition, there is this care coordination element with the centralized Integra complex care management team. We have this rockstar team of community health workers and nurse care managers and social workers who partner with the staff, the AEC, certified asthma educator and community health worker, and can really provide some wraparound supports for the entire family. We've had about 30 families come through that program to date. And we're at the point of kind of scaling it up to increase the number of referring practices. The main pilot practice has reported emergency department reduction among its participants and really a pretty marked reduction in ED use for asthma. We need a little more time to evaluate that with claims data, but we're really, really optimistic about the impact of the program. Next slide, please. I should mention as well that GHHI played a role in helping us to design that program early on. In addition to that, GHHI was one of the folks who applied for the iSpy initiative through the sort of grant, a process that felt like a grant-making process. And they and the Rhode Island Builders Association have been our partners in the home assessment and remediation portion of our asthma approach. So if one of those rockstar CHWs at Integra, or if our partners at St. Joseph's assess that someone has a home environmental condition that could benefit from a professional assessment and then light remediation along the lines of removing the carpets, improving ventilation, we can refer that to Margarita, and she can manage the assessment and contractor process. So we've put 5 households through that process to date, done 3 remediations, small numbers to start, and we're looking about how to grow. Next slide, please. This is just a list of the kinds of issues that the GHHI team is able to address, so including, sort of air quality around combustion byproducts, mold and moisture, pest control, surface conditions, and that sort of thing. And I think, Margarita, you'd like to, on the next slide, talk about just sort of details from one family and also some of the health equity work we've done together.
Thank you, Brady. So yeah, in this slide, we wanted just to share a family story because it is important to showcase that from the families that we service in this pilot, there were some key reduction themes, which was mold moisture, combustion reduction, IPM pest control, and reduction of air leakage. Also, one of the, I will say, benefits of the collaboration is also braiding and coordinating different resources that families did not know that exist. So this particular case study, the family will be applying for the lead program. So we'll be able to also interconnect different resources that the family did not know that they could participate on, and they're actually applying for the lead program since they have children under the age of 6 for this particular case study. So there's a great collaboration of braiding different resources that the family may not be aware of to just increase the health of their home overall within the lens of reducing asthma triggers. Next slide, please. On the next slide, through this collaboration through Integra, we have the ability to request technical assistance, and the Rhode Island Builders Associations and GHHI within the process with Integra, we're looking at how do we measure the equity? How do we engage in families and also the contractors that we're training within this process to really get a holistic approach? Are we engaging the right partners in regards to the training and remediations? Are we engaging community members in the process to remediate the homes that we'll be servicing? So this TA was very important to just measure the questions that we're asking to develop sort of outcomes measures. So it was a great exercise for us to look at the research, the questions that we asked in pre and post, the questions that we asked, and the demographics that we're capturing, and the missing links. So this will be really important work because there's really very little research in regards to contractors. contractors, Black and brown contractors that can participate in this domain. And it was important for the partnership to also grow that, especially geographically, to be able to have community participate in this process as well. And I think, Brady, you have some last comments on the last slide in regards to reflections.
Yeah, I think it's just we think getting to the roots of asthma requires a social determinants of health and a health equity lens, and there's some elements of a comprehensive strategy. It feels to me like this is a moment in time where health systems, accountable care organizations, others, policymakers are paying attention to the social determinants of health, to understanding health equity in a way that's deeper than a buzzword. And so much of the history of the past year with the pandemic and with this sort of racial equity reckoning that I hope we're going through as a nation lead us to take a really sort of comprehensive approach. And it creates some opportunities with health systems to create some programs that really make a difference. So I appreciate the opportunity to do this work with you all.
Great. Yeah. So thank you, Brady and Margarita. We will see. I guess I'm going to just do one. We probably only have time for one question here before we go to break. But I will go and I'll leave this. It'll be just a general question for any of the speakers, so you can unmute yourself and answer. But based on your experiences, what advice would you give to other groups looking to start or expand comprehensive asthma programs in their communities?
So, hey, everyone, this is Langston. I would say start those conversations now, well before you even have the funding. Reach out to the folks on this call, these panelists. We would all love to talk with you. There's so many different ways to provide this service, whether you're using a respiratory therapist, a community health worker, a local public health department, in-house, within the health plan. There's a lot of options, and there's also quite a few ways to fund the program, whether it's through CDC, EPA, administrative rates through the health plan. There's a lot of different options. So don't get stuck on one lane as you're moving through this process.
Did another speaker want to comment on that question?
I can add to that, just to kind of piggyback off of that. It takes a long time to build partnerships and find people who have as much buy-in into your cause as you do. So I just want to reiterate that, start building those partnerships early, find good connections. And I think once you have that infrastructure built, it's a lot easier to ask for funding. And I say that as somebody who's still looking for funding to kind of pilot our comprehensive program. But it's a lot easier for conversation when you know how you're going to deliver the service to say, right, all I need is for you to, buy and then write us a check.
I would add to that, I think, not just building partnerships, but how important it is to find real champions in programs that have a passion about the work and really, have a great interest. I saw in the chat, someone asked about how we connected with weatherization programs. I just picked up the phone and called the manager and said, hey, would you like to be able to, make your program really focus on people that need it the most and it can benefit the most? And she said, yeah. And I said, well, I think I can connect you with those people through the health department. And then I found people like Amira in the health plan that wanted to step out of their comfort zone and try something new and build partnerships. But it takes those kinds of champions who are willing to do something new, something innovative, and just seek those people out and really nourish those partnerships, and then you can grow on them in the way that was said. There is no one set way. Every county is different, every area is different, whatever works for you. But I think those connections are the foundation that you have to build on.
It's felt to me in doing like this that it's been the right move to really build in time for partnership development and relationship development to whatever you're doing, as well as the translational work that requires. Health systems and community-based organizations speak different languages. There's a sort of snarky idea that like CBOs need to be more sophisticated and learn to do what health systems do. I actually think it's the opposite, or at least an equal thing. We all need to get better at talking to each other, and that takes time and focus. And I think building that into whatever you do is the right move.
I would like to add to Brady's comment that I think open communication and continuous communication with partners to build momentum and to, especially during COVID, there's no way we could be able to service families without open channels and creativity in the process to be able to communicate those barriers effectively and really connecting on a regular basis to address those when they need to be addressed.
Thank you all to the speakers. I just want to say, just to sum it up, I think perseverance, partnerships, and program champions are all essential ingredients. And you all definitely demonstrated this last year in the midst of a pandemic, the fact that, you know, all of these programs that we just heard from it during the session, plus a lot more that we weren't able to fit in here. But we know that they've all done great work in this very challenging time. So we encourage y'all to keep up the great work. And on this note, I think we're right on time or 1 minute over, but we're going to give everyone a 15-minute break. And feel free, you know, to reach out to us. We can put you in contact with any of the speakers or any of the programs. So definitely let us know. And we will be resuming at 1:15 p.m. Eastern time. All right. Thank you, everyone. Have a good break.
Okay, testing. I was able to unmute. I can see your video is working, Susan.
Trent, who else needs to be unmuted?
Susan and Kevin. Susan Stepp, and then Kevin from our team.
Hey, Trent.
All right, there he is.
Hello.
Great. Hi, Susan.
How are you?
Doing well. How are you?
Well, it's been a busy morning.
Yeah.
But okay, I'm doing well.
This whole week has been quite busy. We're excited for this session. Now, Susan, are you able to mute and unmute yourself freely?
Let me see.
Great. Yeah, looks like you can.
Susan.
Okay, yes.
Sure, our co-host privileges now, so we should be good.
There's Ruth Ann. She's upside down.
Well, here I come.
There you are.
Am I upside down?
No, not now.
Okay, good. I had taken my camera off. I just wanted to say hello. How are
Well,
you?
great to see you. Great to see you. Thanks for
You
saying
look terrific.
hello. Oh, well, you know, what can I say?
Well, we'll catch up offline. I want to ask you about how everybody's doing. So we'll do that offline, but thank you for being here.
Okay, well, I'm pleased to be here. It's a joy to be here with you guys. So.
Absolutely. You got Kevin and Trent. You can't do much better, right? Isn't that your partners in this?
That's true. And you know what I really love is having your staff around the corner from my office.
Yeah, well,
they do a lot of good deeds for us.
They do. There you go.
Yes.
That's great. That's great. Well, I haven't heard they're causing too much trouble, so that's the best part.
No, they're always busy. I can report if you wanted a workload report. They're very
I
busy.
do not. I do not. They want to tell me all the good work they're doing already. I can't even keep up with it.
Yeah.
That's great. Hey, listen, I'll let you go. Trent, thank you
Okay.
for me jump in there to say hello to one of my favorites amongst many.
Certainly.
Thanks so much.
So I have, I think the plan is to share my screen in about 5 minutes just before we get started. And I have your slides ready as well, Susan. So once I'm done with my presentation, I'll pull those up and advance the slides for you as you go.
Okay.
That works?
Yes, and I have a copy of them, so I
Perfect.
know what I'm doing. Yeah.
All right, I think we're ready to roll.
In fact, there is Sharon Hyde saying hello to everybody.
Okay, everyone, we are going to reconvene here for the second session of our afternoon of asthma convening at 1:15. So if you're able to grab a snack, grab a drink, whatever you want to do to make yourself feel comfortable and settle in for our next session here in just a minute.
Daniela, would you like me to go ahead and get started?
Yep, I'll let you, Trent. Take it away.
Great, thank you so much. And welcome back everyone to this next session titled Strategies for Pursuing Medicaid Funding of Home-Based Asthma Services. We have three presenters today. Myself, my name is Trent Van Alphen. I'm a Senior Social Innovation Specialist with GHHI. After my presentation, we'll hear from Susan Stepp, who is the Program Director of the CHAMP Asthma Program at Le Bonheur Children's Hospital in Memphis, Tennessee. And then Kevin Chan will lead us in a Q&A after that with Susan and the audience. He is also a Senior Social Innovation Specialist with GHHI. So off the bat here, I wanted to do a little level setting. We have a lot of content in this presentation, and we've already heard from other great lessons learned from the previous session, and I think there may be some overlap here. So I'm going to try and get through these slides quickly, and I won't go into detail on everything, but just highlight a few of the recommendations we have here. So our focus here is to share a few insights from on pursuing Medicaid funding for home-based asthma programs. These recommendations in the presentation come from GHHI's experience as both a direct service provider in Baltimore, as well as a technical assistance provider across the country. And we hope most of the content here is applicable to a variety of programs, but we develop them primarily with community-based programs in mind because it's typically a bit more challenging for them to establish healthcare contracts versus programs that are embedded in health plans or providers, for example. And also want to note these slides will be sent out afterwards. They have a lot of links in them if you want to dive deeper into any of the content. So the agenda here today is I'll provide an overview of 6 buckets of recommendations for pursuing Medicaid funding, and then Susan Stepp will present about her lessons learned from their best-in-class program there in Memphis, the CHAMP program, and then Kevin will lead us in a Q&A with her and the audience thereafter. If I know some of this terminology has been used already in earlier sessions, but I did, if for anyone who's new, just want to cover this off the top here, but I'll be mostly saying health plan, and when I say that, I refer to a managed care organization or accountable care organizations such as Integra, who we heard from earlier, or just generally a payer. So I wanted to make that clear. It's kind of a broader term than MCO or other terms. So when I say SDOH, it might use a couple acronyms. That means Social Determinants of Health. CMS means Centers for Medicare and Medicaid Services. MLR means Medical Loss Ratio, and VBP refers to value-based payment or purchasing, also known as alternative payment models. Okay, also wanted to just note, we've talked about this in the first session today, but GHHI has supported a lot of healthcare partnerships across the country, over 30 in fact, including the one we're directly involved in Baltimore. And we've helped about 8 programs secure Medicaid funding in different sites, which you've noted here on the map. Now, to start off, before we get into the recommendations, we wanted to hear from you all and give a little poll here. We're curious if you can, I'll put up the poll here, but the question is whether you work for an asthma program directly or are trying to contract with one. We're curious where you are in that process. So I'm going to launch this poll if I can figure this out here. Okay. Daniela, I'm sorry, I'm not seeing the polls for this in here. I'm seeing polling. Oh, never mind. Okay, I'm sorry, I'm figuring it out. I think, or almost. Okay,
Trent,
so
Trent, if you
I'm
want to just
gonna-
there you go. Yeah, leave it there for to let everyone start polling. And then once you're finished, once you've given them enough time, you can click the end polling button and it'll give you the result.
Okay, yeah, I didn't see the drop down at the top.
You can have the share polling results as well on that second option once you put end polling.
Great, thank you. Give everyone 5-6 seconds longer to fill in your results. I see a lot of results coming in. Okay, I'm gonna end this poll, share the results, hopefully. It looks like most of the audience is in early research or exploration and early discussions, which is great. And we even have a few that have secured funding contracts, about 16%. So that's awesome. Good to know. Okay, moving on here. So as I mentioned, we wanted to categorize and bucket our recommendations from our experience and those of our partners. And we narrowed it down to 6 key recommendations. First is understand relevant Medicaid policies, authorities, and payment mechanisms. The second is understand what motivates Medicaid health plans and providers. And third, know your program's performance and impact. 4, be strategic in building relationships. 5, be strategic in contract negotiations. And lastly, research existing contracts and learn from programs involved. And from listening to the lessons in the field session, I think all of these have been touched on at least already today. So we'll dive a little bit deeper and provide some additional content here that you can explore in more detail later. So this first one, I wanted to just quickly cover some basics around Medicaid funding that most of you probably know, but federal CMS provides a portion of every state's Medicaid budget. So ensuring that they get that approved federal match is very important to states. And when that gets funneled into the contracted Medicaid health plans, they have to adhere to the medical loss ratio, which requires health plans to spend at least 85% of their premium on medical and quality improvement expenses, and a max of the other 15% can be used for administration, marketing, salaries, etc. So that's referred to as the admin or administrative spend typically. And each state has their own state plan that lays out exactly what services are covered. Home-based asthma services, as we've already discussed and many of you know, many of these services are not covered or undercovered by Medicaid in many states. And I wanted to point you all to a great resource that we've linked here called, it's the American Lung Association's Asthma Care Coverage Initiative. And it details exactly what is covered and not in each state. So this 15% administrative portion is obviously more flexible. So a lot of health plans use that to pay for non-covered asthma services. But because of that cap, it's limited and less sustainable. So that can be sort of it also competes with a lot of other priorities. So that can inhibit the scale and sustainability. Here on this slide, I'm going to list just a bunch of common mechanisms to enable coverage of home-based asthma services, but I want to just highlight a couple here at the top. The first are state plan amendments. These are permanent CMS-approved changes to a state health plan. We've seen a lot of states such as Missouri, Oregon, pass SPAs to allow coverage for community health worker services that implement home-based asthma services, and they reference often what's known as the 2014 Preventive Services Rule Change. And we've also seen some pass certain SPAs known as CHIP Health Services Initiatives. And these are expansion of coverage for services that are targeting children. And a lot of those relate to social needs. Next are 1115 demonstration waivers. These are more temporary payment and service delivery reforms within a state, but they're multi-year, typically between 5 and 10 years. And these can become permanent through state plan amendments if they're successful. And there are certain demonstration waivers known as DSRIP waivers. That means Delivery System Reform Incentive Payment Programs. A mouthful there, but I think 3 states where there's a lot of exciting momentum around social determinants of health through waivers are New York, Massachusetts, and North Carolina. So I encourage everyone to check those out and see what's going on in your state as well. And we've linked here to a list of DSRIP waivers. A few other common mechanisms are managed care contracts, quality improvement activities, community care coordination services, and targeted case management, which allows some potential for coverage of certain asthma services. Value-added services provide a bit more autonomy for the health plans to cover some of those voluntarily and count those as medical spend, but they're not actually included in the premium for health plans. Lastly, I wanted to highlight an exciting initiative in California through what's known as in lieu of services. And they are proposing some reforms there to designate asthma-related home remediation specifically as an in lieu of service, which would essentially make it a covered service, which is really exciting. And here I want to provide 2 links. First, to a letter that CMS put out earlier this year in January that lays out all the Medicaid mechanisms to address social determinants of health. There's not really anything new there, but it clarifies what the existing mechanisms are, and they actually give a shout out to GHHI and a portion of them, our program in Maryland, which we were excited to see. And the second link here is the Financing in-Home Asthma Care website on the Asthma Community Network that was mentioned by Tracy in the first session today. A lot of really great resources there as well. We expect a lot more activity around social determinants and more flexibility across these mechanisms, maybe new mechanisms as well to pop up here in the near future. Okay, second bucket is understand what motivates Medicaid health plans and providers. From our experience, we've seen the state requirements and incentives to be a big driver of health plan activity. New York, I mentioned their waiver. They actually require health plans to address social determinants of health in certain value-based payment contracts. Michigan, I believe it's a quality initiative, actually withholds 1% of a health plan's premium until they execute a contract to address social determinants. And then a lot of health plans really care about quality measures and performing well on those that are designated by each state, because those are tied to how the health plan is rated across the state, and also can be tied to certain incentive payments for the health plan and their providers. Second, of course, health plans care a lot about providing good care to their members. You may have heard of the triple aim, providing better health outcomes, better quality care, lower costs, and there's increasing activity around social determinants of health. They're also very interested in engaging and retaining their members. So hard to reach members, making PCP connections, for example. These are all things that if you can highlight would be very attractive to a health plan if you can do those through your program. And lastly here, they care about economics, the bottom line, being a leader in the market, increasing their market share. They care about return on investment for any programs. The medical loss ratio, complying with that is very important as well. Okay, so the next bucket here is to know your program's performance and impact. I wanted to just shout out the M-Home publication that we already mentioned earlier that provides recommendations for metrics and standardized metrics based on the input of experts. I encourage everyone to check that out. We've linked to that here. A few recommendations I wanted to highlight here is that many of the sites mentioned in the lessons learned, but we encourage everyone to be urgent about evaluation planning and implementation. Start on it as soon as possible. Focus on gathering evidence for not just outcomes, but also process improvements, and then get as much evidence and from a variety of sources as you can, whether it's survey data, case studies, working towards the robust administrative data from healthcare entities if you can, and use it all to build compelling funding proposals or cost-benefit analyses. Local universities can be great partners. And then there's pretty high threshold for data security for health plans to contract. And so if you can get started on a data security plan and infrastructure to prepare for that as soon as possible, that'd be great. A couple great success stories. We'll hear from Memphis Champ and what they've done, but a lot of their data and evaluation work has led to new opportunities, as well as in Baltimore and Salt Lake, our partners out there. A lot of the internal analyses by health plans grew into funding contracts when they noticed the impact of these programs. Okay, next we wanted to release another poll here. And we were curious where you're at in the process of evaluation and or analysis, whether you're looking to partner with an asthma program or work for a program directly yourself. Where are you in that process? Any evaluation or only process evaluation, cost benefit analyses, or if you're able to get to that robust administrative data, we'd like to know. We'll give you about 5 more seconds here to complete the poll, and then I'll release the results. Okay, I'm gonna end the polling now and share the results. All right, well, it looks like there's some work to do. Looks like a few sites have gotten to some cost benefit analyses and robust evaluation. A lot was self-reported, but it looks like a lot have some work to do. So hopefully you will connect with these programs we've highlighted here and learn how they did it and get started on that. Okay, I'm gonna go through this slide quickly, but we've heard from sites on building relationships and recommendations around that. We want to just kind of highlight an example of how a relationship may unfold with a health plan. Maybe you start with educating them about the program, inviting them to a stakeholder coalition. Maybe you work together around policy initiatives, and that could all lead up to a contract for a pilot, and then exploring more sustainable models. But I did want to note that it's often an iterative process here. So some recommendations is to connect with staff at different levels of a health plan. Health plans often have frequent turnover, so that can lead to challenges, but also new opportunities. And then look for opportunities to advocate for policies together, and look for what local stakeholders may have additional resources you can leverage, like a lot of city housing organizations that get HUD grants may have some funding to cover some asthma services in your program, so you can work on cross-referring with those programs. Okay, this next bucket of recommendations is to be strategic in contract negotiations. As early as possible, we encourage you to have internal discussions about what types of payment structures you would be comfortable with, what portion of administrative and overhead you could incorporate into the fees that you propose. Understand, what you absolutely need to have and can't budge on in a contract negotiation versus some things you may want to propose up front but have some flexibility on. And talk about what risk you may be able to take on if you're looking at a value-based payment contract. during negotiations, ask about what constitutes success for all parties involved, and try and gauge a health plan's or provider's ability and willingness to increase the scale and funding if you're showing success. And ask about these things up front and see if you can get some contract requirements for the health plan to support enrollment via warm handoffs or to share data, for example. These are all great strategies. Okay, our last bucket here, I'm going to try and finish up quickly, is to research existing contracts and learn from programs involved. So, for example, with some of these sites we've highlighted here today, call them up or ask GHHI to make a connection for you and learn from where their success. Probably the most common type of contract we've seen is a direct vendor contract, which is basically just a contract for the non-covered services that you can't bill Medicaid for. And it's often combined with a provider contract for covered services if the asthma program has clinical components or services that can be billed for. This, as I mentioned, is paid for out of the health plan's administrative budget, so that can limit the scalability and sustainability in some ways. Hopefully, this would be a step towards a more sustainable contract, and the specific payment structure is negotiated by the parties. The bottom of the screen here, there are 3 examples we wanted to highlight. Our program with Amerigroup in Baltimore was developed out of an internal analysis of outcomes they did, and we got renewed for that. In Michigan, there's a great contract between Healthy Homes Coalition of West Michigan and Priority Health. And then in Salt Lake County, they are partnered with University of Utah Health Plans, and they actually renewed their contract as well. And that's actually just for home remediation services, and the health plan does some of the home visiting for asthma education. On the horizon, looking forward, we expect to see a lot more asthma programs involved in value-based payment arrangements and alternative payment models. So that you probably know, but this is a shift away from the fee-for-service traditional model into more tying payments to value, savings, quality measures. And there's a lot of varieties of different payment structures that we've linked to here. And we'll show an example of one at the bottom here in a bit. But this contract for value-based payment arrangement must be between a health plan and a certified Medicaid provider, typically a health system. So if an asthma program is embedded in a health system, it's typically a lot easier. But I do want to note that a lot of community-based asthma programs can contract with a health plan or a provider in support of an existing value-based payment project. This is much more flexible. These count as medical expenses, so it's seen as more sustainable and helps programs get actually funding for the impact they make. So we're excited about new opportunities popping up around value-based payment in the future, and it's very complementary to the activity that we see increasing around social determinants of health as well. So a couple more just recommendations is to do some research and understand what activity is happening in your state around value-based payment and social determinants of health, and understand how your program impacts quality measures and how it can support a VBP arrangement, and then reach out to health plans and ask them about them. This example here at the bottom is one where a health plan or provider may provide a prospective per member per month payment upfront to an asthma program, and then get a retrospective bonus payment based on the impact on savings and quality on the back end. So it is a little bit of risk, but it's just upside risk. So if you can float some cash for a while you wait for those back end payments, this could be a great option. And we've worked with some partners in Texas that are working towards a model like this. And lastly, here's the link to GHHI's resources around value-based payment. We have some few publications there. Whew, okay, so that's it for the presentation here. One last poll. I was curious to hear, among these 6 buckets of recommendations, what do you think, based on your experience, is the most important for pursuing Medicaid funding of home-based asthma services. So the poll is up. Please answer quickly, and I'm gonna start getting Susan's slides ready for her portion while we're letting these results roll in. Okay, about 3 more seconds and I'll close the poll. Okay, share the results here. Interesting. So the first bucket, understanding Medicaid policies, authorities, and payment mechanisms, is the most popular, followed by what motivates Medicaid payers, providers. Good stuff. Thank you all for participating in that. I'm going to close the poll and we will move on to Susan's step, and she will give an overview of the CHAMP high-risk asthma program. She's a longtime GHHI partner and has had just tremendous success out in Memphis with their asthma program at Le Bonheur Children's Hospital, and she's the program director for that, and we'll provide an overview of that, after which we will lead into the Q&A portion. So if you have questions for Susan, please put those in the chat as we go. Let me pull up your slides here, Susan.
Okay.
Can you see those all right?
Yeah, there we go. Good afternoon, everyone, and thank you, Trent. Thank you, GHHI, for the opportunity to share some information today. I certainly can't tell you that I feel like an expert in this area, but I like to think that I keep learning as we go along. So I want to give you a little context about our situation so that my information can sort of fit better. As Trent said, I work with Methodist Le Bonheur Community Outreach. We are linked to Le Bonheur Children's Hospital, but we also are in a system that has 6 hospitals. And but it's important to note, my division of community outreach is actually a separate 501c3. We are part of the corporation, we're part of the hospital family, but we do not work inside the hospital. We collaborate with partners in the hospital. And through our work with CHAMP, actually, my role has expanded. I'm actually the Director of Chronic Disease Management, and I've started working with diabetes and HIV as well. So with that said, I want to tell you a little bit about CHAMP. So if you want to go to the next slide, that's great. So what is it? I'm going to be kind of short and quick here. It is a multidisciplinary program to improve asthma management for high-risk asthma patients. I always make that distinction because there are so many children in Memphis who suffer from asthma. But we specifically have targeted those children who are the highest risk, those who frequent our hospital. So if you're part of a hospital system, you know, you've got hospital data. And so you use what you have, and that's how we have defined that population of children that we're trying to serve. So our intervention includes medical services that are billed in the normal, regular way for medical services, and then there's the community-based elements. Next slide. So our criteria is fairly simple. All of our patients reside in Memphis. We are focusing on high-risk, poorly controlled patients. And typically, and I say typically because we're about to change some of this, or we're exploring new opportunities. What does high risk mean to us? It means you're at the hospital a lot. You've been there in the emergency room 3 or more times in the last year. You have been admitted maybe some of those times, and of course, any child who's been in our intensive care unit would qualify for the program. All of our patients have Medicaid, which is TennCare in Tennessee. And this is very important. I listed this because I wanted to say it early. Why only TennCare? For sure, that is a high-risk patient population for us, children living in poverty. and we have a very high childhood poverty rate in Memphis. But we also have a unique relationship with TennCare administration in Nashville. And part of our system and part of what I think has helped us to develop this program is our access to Medicaid charge data. If our goal is to reduce exacerbations, to reduce hospitalization, to increase medication fills, controller medication fills, then we have the hard, fast data that shows us if that happened or not. So it's critically important in the operation of our program. Next slide, please. So what are our metrics? How do we measure success? Reduction in hospitalization, and we do that through a comparison of pre and post-test intervention, once again, because we have TennCare data. Reduction in total exacerbations that require any level of medical care. And then in more recent years, we've realized that there are other things that are important and other things that contribute to the total healthcare picture. And those basic quality metrics of the asthma medication ratio. And we have really tried to focus a lot on all of our children, reinforcing the annual well child visit or the EPSDNT screen. Now, I put an asterisk by cost of care. We started out on this business thinking that was the most important. And in fact, there's significant data that shows that CHAMP does result in a reduction in cost of care, around $2,000 per child per year. But we have also learned that cost of care is not the only game in town. There are other things that would be appealing to a payer, and that might provide interest in funding the program. Next slide. So basically, just to tell you what our medical services are. Now, remember, this is a high-risk population. And so the ability to provide medical service and improve access to care. I know Trent mentioned the triple aim. Access to care when you really need it is pretty important, particularly for an underserved population and a population that has not had a good experience of care. That is one key aspect that we really try to emphasize. So we do a medical evaluation in our subspecialty clinic. Dr. Christy Michael is our medical director. She's an asthma immunologist. We provide certified asthma education in the clinic with our RT and we have an RN. And one of the most successful parts of our program is also access to a 24/7 call line. Our medical staff wrote the protocol for the line. It is answered in the LeBonner emergency room by EMTs. And there are some nurses that participate in that. Our nurse carries a cell phone, sick call triage on weekdays. Again, these things promote access to care when you really need it. We've also worked with the school system, the local Shelby County schools and charter schools in Memphis. Of course, schools have been sort of a mixed bag this year with COVID and all, but still, we still have those connections. We provide emergency medications for children and instruction to nurses for each of our patients. Next slide. So of course, I always have to show this picture because this shows what we're doing in the field, in persons' homes. This person is the amazing Raisha Montgomery. In this picture, she was a community health worker. She's now supervisor of the community health workers. But these folks are well-trained in the basics of asthma. And I'll let you go to the next slide, Trent. Reinforcing asthma education, being able to speak the language, like why is this important? What does that controller medicine do? And helping you explore all those reasons why that may be a challenge in taking that medication. So I've got some things listed here. Spacer use, you know, can we help you develop a schedule to take the medicine? Do you need help to get the medicine? We can go get the medicine. How can we reduce the barriers to all of the information and all of the training that you've had in our clinic? Environmental concerns are a major issue in Memphis, Tennessee. Like most cities, large cities, I guess, we have pretty poor housing stock, and a lot of people struggle to keep that environment as safe as it should be in order to support the health of their children. So we do the the EPA environmental assessment, and identify triggers, provide information and education, cleaning supplies. But in so many cases, there's so much more that needs to be done. Often finding ourselves providing advocacy with landlords, and the next slide mentions our medical legal partnership. Many children's hospitals have that. We have been very proud to be able to work with them. And go back to the other slide, Trent, just a second. Oh, and I wanted to mention that our community team also does a lot of case management because of our availability of data and the TennCare data. In our platforms, we're able to see when filling medication may be a problem. We're able to note when the last time an EPSDNT occurred. So part of our ongoing effort after we've delivered at least 3 to 4 visits up front is touching back with people, checking the data, and reaching out as we need to do that. We also receive a lot of calls for social.
Oh, Susan, I think you went on mute there for a second.
Oh, okay. So, next slide. I want to share with you the outcomes. We have had the ability, we have an evaluation team as part of our organization. And of course, I've already told you about the availability of the data. So each year, of course, we produce this report, and it has been pretty much the same for the past 5 to 6 years of the operation of the program. This report covers 825 children who, as of December 31st, had completed 1 full year prior to the program, and then 1 full year for the pretest and the post-test, the comparison of the data. Now, we have served more than 1,000 people, closer to 1,100. But so this is based on the children who were part of this at the time the data was drawn. But 59% reduction in emergency room visits, and that's 1 year, the previous year prior to enrollment compared to 1 year after enrollment. 71% reduction in the inpatient hospitalizations and observations. And of course, this is where the cost savings comes in. When we reduce these costs, with these events, there's cost savings for the TennCare administration and the payers primarily, which is another good point to make when you're approaching them for money. Reduction in urgent care visits, 56% reduction in total asthma exacerbations. Again, we mine this data out of the TennCare charge data. Again, at the end of our CMS Innovation Grant, CMS did conduct a research study, a matched group of children. They were able to get TennCare data to do that. And that's where it was found that there is a significant cost reduction with the delivery of CHIMP services. So, at the top, I've said outcomes pave the way to sustainability. Because after that grant ended, we had to make some decisions about how we were going to move forward. And our ability to show the outcomes provides impetus for our own organization to invest more in us and to help more. So next slide. So I guess here's some of the lessons learned for us. And let me first say that after our grant ended, our hospital was willing to go forth and not only help us find some philanthropic funds, but to fill in some funds for themselves. Interestingly enough, when we reduce hospital encounters, we reduce hospitals' income as well. So I think it's a good thing to be said about our hospital that they were more interested in the health and welfare of the children. and willing to go there with us. So we have been able to maintain with philanthropic funds for several years, and then we began to look to the payers to add the funding streams. And that's really where we are. We're in the middle of this, basically. But I feel like our key to being able to continue as long as we have is that we do have a very strong and specific problem statement and a well-defined target population. We know who we're going for. We know what kind of patient we can serve, and we can find them. We're part of a hospital. We can get a daily report that shows us the name of every child who comes to the emergency room. We have that information in real time, and it gives us the opportunity to reach out to those families in real time. Our goals are specific and measurable. And again, we have a means to get that data. That's a lot. I had to put that in there. I mean, those are critical chunks to be able to build a program and to be able to monitor your success, gauge where you are. Always collecting and evaluating the data and being nimble enough to respond to it. Clearly, the CHAMP program that exists today is not the one that started, back in 2013. Several things we realized just don't work the way we thought they might. They looked great on paper, but they aren't real. So we had to move beyond that, and the data helped us make that decision. Next slide. So here's only my opinion about what may appeal to payers. Again, results work. Being able to show that you've made a change. Or even being able to show and being, I think, open about some of the challenges that you've had. I think people, I like to think people do respect the truth. Some things recently made me challenge that, but I think we're back to the right place. Going on, scalability is an issue that we have run into in our program. I said earlier, there are thousands of children in Memphis, estimated 18 to 20,000, with asthma. Not all of those children, in fact, most of those children would not qualify for this program. And often payers are interested in those programs that are scalable to a great degree. But we deliver a pretty intensive service to a fairly small group of children. And of course, that small group of children can account for a lot of healthcare costs as well. Quality measures are important. We learned this 3 or 4 years ago, that there's more than cost savings and hospital utilization. And some of the things that come to mind that we've been working on, we now look at the AMR, that's the ratio of controller meds to all asthma meds. You didn't see that in my data, but like, for example, we've done a calculation, particularly for our United Healthcare kids. We do have a contract with them, and we have an AMR of 0.71 for those children. So, that's pretty good. That's where we want to be. But there are some other things that matter to payers in terms of those quality measures: lead screening, child immunization levels, annual well child visits. I think I said it earlier, we strongly try to promote those. In our United Healthcare group, 91% of those children had an EPSD&T last year. That's pretty good. And now we don't take them there. We just sort of talk it up and try to remove the barriers that would help them to do that. Flu vaccinations are another thing, and I think we actually can give those in our clinic. And if you're dealing with programs that deal with older people, because some of the programs are dealing with COPD or adults with asthma, anything that's related to fall risk. But those things can be important to payers too, if you have a chance. And the ability to save money, the ability to save money. But again, I'm not sure that is the most important thing, and surely not the only thing that people should focus on in trying to appeal to a payer. So that might be my last slide. I don't know. I haven't looked at my own slides. Oh, no, it isn't. So let me tell you where we are. We've noticed, I've got out there the fee for service versus a vendor contract. The first opportunity we had to have to get payment from a payer was from Blue Cross Blue Shield, Tennessee. And how did I find those people? Well, I actually met Fran Martini at a conference, and she and I were actually co-presenting. And so that's how we developed that relationship. And we then, it took a couple of years, but we developed the capacity to bill Blue Cross Blue Shield for home visits. Now, again, the medical aspects of our program, which are very important, and I'm specifically now talking about coming into the clinic and seeing the doctor or the nurse practitioner. That's built through the medical system. That's not part of the budget that I manage. So the Blue Cross Blue Shield service does bill for the home visits to our patients that are provided by our community health workers. They also will reimburse us for a school visit, which is typically done by our respiratory therapist. Then we have a vendor contract now with United Healthcare. And that is the kind of contract that we all would rather have, because we receive a monthly minimum payment per patient for the service delivery. And of course, the fee for service was a great thing for us to do in the beginning. I really wanted the foot in the door to be able to work with a payer. But the vendor contract is really the type of payment structure that helps to pay for the program, to run the program. And of course, the fee for service requires us to work within the electronic medical record and to drop bills in a similar fashion. So, I mean, there's a lot of moving parts in that whole piece, rather as the vendor contract is getting an invoice, submitting an invoice and getting paid. Again, the healthcare reimbursement, and I think this is probably true totally, and will be for us. We don't expect that 100% of our costs will be covered in the healthcare payer. That's what we're shooting for, but some level of philanthropic work and grant funds, because we are also involved in local grants and grant programs. So that kind of, I guess that is my last slide. And so Trent, Kevin, I'll turn that over to you.
Okay, great. Thank you, Susan. We've got a lot of good questions. So I think we will get to as many as we can. I think the one that was asked the most was, Susan, I'm not sure if you can hear this, but I think there's some kind of feedback on your end that sounds like a tea kettle. So everyone's curious what type of tea you're drinking. But all joke aside, I'll get to this list of questions here.
It might be the headphones.
Oh, the headphones. Okay. Oh, that's better.
Okay, there was background noise, and that's why I used the headphones. I'm sorry.
No, that's fine. Thanks. Mm-hmm. Well, great. I was going to kick this off with sort of a question related to what Trent was talking about in terms of, building strategic relationships, specifically with payers. And, I know, you've been talking with the MCOs for years and years now, and sort of, had starts and stops. And it's great to hear that you've made the progress that you have over the years. But I was curious if you had any recommendations about how to sort of maintain that momentum. Even if there are lulls in those discussions, how do you make sure that, those conversations are still happening and keeping that momentum and moving towards, contract negotiations and talks like that?
Well, one of the things I failed to mention was the importance of GHHI actually helped us a great deal in terms of linking up with payers. we had, of course, we've had a contractual relationship, had worked together in the early years of the CHAMP program. But one of the important things I wanted to mention too is I kind of sort of got at this. How do you find these people? How do you get to them if you don't know them? And I mentioned I found Fran on my own. However, I was connected to United Healthcare by GHHI and Michael McKnight. And one of the things that we did, and we collaborated on this, is once you get your initial conversation, of course, you always want to have a next step. So, okay, it's great that we told you all about this. Now what? And trying to follow up. And sometimes that process involves, am I talking to the right person in the organization? And helping to, if you have that initial conversation and realize that, well, that person seems interested, but they don't really, they really need to pass you off to someone else. And I think GHHI was helpful in the process of helping us weave through some of those organizations, because my project isn't very big. I don't make a big impact. It's not like I can come representing Le Bonheur Children's Hospital. I'm only talking about one specific portion. So I think consistency, finding people who know the right people, and then always make sure that one conversation is going to lead you to the next. And when you're asked for information and you don't have it, try to find it, try to get it. I just can't emphasize enough the importance of having your ducks in a row in terms of your data in the very beginning. Present what you've got.
Great. Yeah, thank you, Susan. Moving along to data, there were a few questions about data I think are going to be interesting. I guess first is there was a question about a link to your sustainability report. I think you mentioned a 2020 report and folks were interested in taking a look at that. Is that available online or something that can be shared?
It's not available right now, but let me talk to our director of evaluation and we'll send that, make that available. Should we send it to GHHI to distribute or?
Sure, yeah, we can do it that way. Yep.
Yeah.
Okay, thanks. There was a couple questions about COVID, and I think a lot of folks across the country are seeing reduced utilization due to COVID. And so the question was, if you've seen that children with asthma have, fewer hospital encounters with or without the program, and if this is something that you've seen, is there a way that you account for this in the data? And yeah, so I guess we'll start there.
Yeah, well, yes, hospital utilization has certainly been much lower throughout all of our hospital system, but particularly in the children's hospital. So that means that our actual enrollees has been significantly less in 2020. Now, the data we've got was based on people enrolled at least a year before that. So it's the upcoming data that probably would see a lot of impact on, may see a lot of impact on that. But, well, I mean, it's true that when children aren't going to school and if they're staying at home a lot, that seems to reduce a lot of the asthma exacerbations. But we are seeing an uptick now in the hospital utilization. Not that that is a good thing necessarily, I guess, but certainly we know that COVID changes the model and that we all operated on. Our clinics seem to be as busy as it was, and of course use of telehealth. But for sure, impact in the number of patients that we have enrolled in 2020.
Great. Yeah, and I think this is something that we're seeing across the country. So certainly a trend in the data and, something that we'll need to account for when we're looking at the 2020 data. There were a few questions about sort of related to the programmatic and operations of CHAMP. So the first one is, you mentioned that respiratory therapists coordinate, care management with schools. So do you have school nurses in every school in Shelby County? And if not, does the RT coordinate that care with them?
Well, Shelby County does not have a nurse in every school. They tend to have one nurse for 5 schools, which is not very effective. However, we still actually do a visit with that nurse, and then we end up also talking to the other people who are available when the nurse is not there. I mean, that's one of the difficulties of the situation. Obviously, if a child is going to experiences an asthma exacerbation in school, somebody is going to respond. So we're going to not only talk to the nurse, we'll coordinate with her, but we'll be talking with those other people that are identified. We also, in years past, and hope to do this again. Now, like we typically hold an annual asthma training for all school nurses in Shelby County. Those are some things we weren't able to pull off, but we will get to do again. But as you know, it's the daily care. It's who's going to respond in the moment when the child is ill, and but we try to make sure every child has a packet of rescue medication, a copy of the asthma action plan, our number, and yes, we do get called in the moment, so that at least someone there at the school could access us if they needed it and knows what to do.
Great, thank you. A question about scale. So how many kids does CHAMP see every year? And what does that equate to in terms of number of home visits, or I guess number of home visits per children or per child, if that's a sort of an average standard that you shoot for? And then related, what does the staffing look like in terms of FTEs? So I think, if we're talking about someone who's doing home visits, how many children or families do they see every year or at any given time?
Well, at any one time, we have around 450 active patients. We have 3 community health workers. And so you could see roughly what that caseload might look like. The actual flow of the work is front loaded with initial clinic visit, home visits. Our community health worker actually does enrollment. We do enrollment in the homes. And now we do it via telehealth, and we run the paper back and forth. We do operate under an IRB, so we have informed consents and those sorts of things. But initially, the way the program is designed, there is an initial home visit and with enrollment. Then there's a clinic visit. That's where we establish the asthma action plan. And there's the formal asthma education, and then the community health worker is then reinforcing those things. We then go with the environmental visit, see what kind of other services. SDOH is always an issue too. I mean, during COVID, we've done a lot of delivery of food and toilet paper. So originally, early on, we did a lot of that. And then the ability to use the data. Obviously, if we have identified needs, we're going to be checking up on those needs. And remember, I said we have a 24/7 call line and a nurse call triage. So if somebody calls a 24/7 call line, we immediately know that because we get an email. All of us get an email. And then, so we're following up as needed. Like our nurse will follow up, and then our community health worker will follow up to see what more we need to do. If we see in our data that someone isn't filling their asthma medication, we're on the phone and we're trying to connect with them about that and picking up that medication if we need to, or doing what we need to do to help them with that concern. So there are a standard number of visits, 3 to 4 that happen in the beginning. There are other visits as needed, determined by the needs that are established. And then there's responding to the 24/7 and also monthly case management, looking at our data and reaching out to our families based on what we're seeing in terms of the data. So we do as many visits as we need to do, and I think another important thing is our patients typically go back into the clinic at least quarterly in the first year, probably less than that in the second year of their enrollment. And so the communication between the community-based team and the medical team are pretty important. And often the medical team will identify something and then call the community team into play there. I have a chart that shows how this works if it'd be helpful for people to see it.
Sure, yeah, we can include that in the packet as well. Yeah, I think that would be great. Well, thank you, Susan. That brings us to 2:15, so right on the dot. We had a couple of questions we didn't get to, so maybe if Susan, you can stick with us, I'll chat those over to you and see if you can maybe provide some written response to that. But yeah, with that, I'll hand it back over to, I think, Daniela or Trent.
Yep. Thank you very much, Susan and Kevin and Trent, for a great session there. We are going to give you another opportunity to stretch your legs. We know that it's a long half day here. We want to make sure you can grab something to eat or something to drink, take a bathroom break, and meet us back here at 2:30. We're going to have a really exciting panel coming up with members of the Federal Asthma Disparities Work Group or Subcommittee, and you won't want to miss that one. They've got some really great information to share, as well as GHHI will be sharing some information around some of our asthma advocacy and policy recommendations. So feel free to take a couple minutes break and meet us back here at 2:30. Thank you. Okay, I'm just going to give everyone the couple-minute heads up here. We're at 2:30 in about 2 minutes on my end. We're going to launch into our next session. Just giving everyone a heads up if you needed to get a drink, get any snacks you wanted with you for the next hour or so, or anything else that might make you more comfortable. Now's the time. We'll get started here at 2:30. Thank you. Okay, that was quick. Well, we are about to get started here. Thanks for spending either some of your day or a large part of your day with us so far. We're really excited to have you for this afternoon session. I'm going to get us into our next session here on advancing asthma healthy housing in 2021 and beyond. With us today, we are going to be having a great panel of experts from the Federal Asthma Disparities Subcommittee. I can show you who our panelists are. We've got Michelle Freemer of NIH, Peter Ashley of HUD, and Tracy Washington-Enger of EPA. And my colleague Mike McKnight will also be joining me to help moderate this discussion and provide a little bit more information advocacy recommendations for this year. So without further ado, let me introduce our first speaker. We're going to be hearing today from Michelle Freemer at NIH. Michelle is trained in pulmonary and critical care medicine at the University of California, San Francisco, where she also joined the faculty. Her experience as a pulmonologist guided her transition to designing and conducting clinical trials at Intermune and later at Genentech. And then joining the Division of Lung Diseases at NLHBI in 2012, Michelle oversees a clinical portfolio focused on asthma, minority health, and behavioral interventions. Collaborating with federal partners in the Asthma Disparities Working Group is a priority for her as part of her work. So without further ado, we have Michelle here by audio, and I also have her slides. Michelle, can you hear us? You should be able to unmute.
Yes, I can.
Great.
Yes, I can.
I'm going to turn it over to you and start with your slides. If you would like to.
Okay, terrific.
There we go. Okay.
If we can go to the first one.
Mm-hmm.
Great. And then the first slide.
Yep.
Thank you so much. So we're thrilled to be here. As Daniela said, we're actually representing a subcommittee of a group of federal agencies known as the President's, sorry, can we go back a slide? Known as the President's Task Force on Environmental Health Risks and Safety Risks to Children. So basically, this is a group of federal agencies focused on the environment and how it affects the health of children. And the Asthma Disparities Group is one subcommittee, and we were really one of the first groups formed as part of this task force. So this work has been ongoing for many years. And if I can have the next slide, what we'd like to cover today is just to answer a few basic questions of what we see as the problem, who's working on it, and how we've approached the problem. And then I will shift for the second half of my talk and consider what specifically the National Institutes of Health, where I work, and specifically I work in the National Heart, Lung, and Blood Institute. Sorry, it's kind of a mouthful. And where we focused our efforts on asthma disparities, and then think a little bit about, because we're focused on research, when research will be ready to integrate with other efforts, such as those being done by our other federal partners. Next slide, please. So in terms of the problem, I think this group is probably very well versed in this, but essentially, if you look at the navy blue line, which might be a little bit hard to distinguish, but it's pretty much in the middle, and you can see by looking over time from 2002 to 2018, and the prevalence is going vertically, you can see that the prevalence hasn't changed that much if you look at all children. On the other hand, what has also remained constant, unfortunately, is the fact that this group in dark purple and bright pink, representing Puerto Rican children and Black non-Hispanic children, has consistently been significantly higher than all American children. And so it's actually this difference that we consider a disparity, and is what we want to actually address. And if I can have the next slide, it's not simply that children in these groups actually have more asthma or are more likely to be diagnosed with asthma, but as you probably all know, this is data from our colleagues at the CDC, who's one of our partners, on asthma attack prevalence or exacerbation prevalence in children with asthma. And just highlighted here, you can again see that particularly for Black boys and for Puerto Rican girls, their rates exceed that of all other groups. And so this is the issue that we're trying to address: is why are there such disparities in terms of why these children are experiencing more morbidity and more burden from their asthma, as well as more children within these groups are actually affected by asthma. And so that's the problem that we're trying to address. In terms of who's working on the problem, that's our next slide. We are a group of federal agencies, and essentially there are multiple agencies. On the right-hand side of the slide, you see agencies that fall under the Department of Health and Human Services, which includes our partners from the Centers for Disease Control, the CDC, as well as the NIH. And I should mention that it's not only the Heart, Lung, and Blood Institute where I am, but several other institutes. We have 5 institutes within the NIH that contribute to our work on asthma disparities. And then in addition to GHHS, there also are a number of other federal agencies, and our biggest partners here are those from the EPA and HUD, who you'll hear from in just a few moments. The co-chairs of the group are actually from EPA and from the NIH, but really there's a very strong team leadership between HUD, EPA, CDC, and the NIH working on asthma disparities. If I can have the next slide. So what's our approach? How are we actually addressing disparities? So in May of 2012, we launched what we call the Coordinated Federal Action Plan to Reduce Racial and Ethnic Asthma Disparities. This document, which is somewhat lengthy, actually is divided into 4 strategies. The first is essentially to reduce the barriers to implementation of the asthma guidelines. The second is to ensure that children receive comprehensive asthma care. The third one was to identify the children that are most impacted by disparities. And the fourth was to consider how can we improve our efforts to actually prevent asthma in racial and ethnic minority children. If I can have the next slide. So in terms of why we work together as federal agencies, obviously for many of us, we have a mission within our own agency. And so the idea of this collaboration is really to use existing resource, but optimize our impact through synergies. That is to say that we're collaborating with one another to try to improve the product and what we can deliver for children. And we really like to emphasize the activities that can address preventable factors that impact asthma disparities. So not just things that might make numbers look better, but things that can actually improve outcomes for children with asthma. Next slide, please. So as you might imagine, I briefly reviewed the 4 priorities that we had in our coordinated federal action plan, and to divide that large body of work into sort of chewable pieces, every couple of years we have refocused our efforts in 3 areas, figuring that we can focus on 3 things at a time. The one that has remained essentially the constant from 2013 through the present time is the one of most interest to this group that Tracy Washington Enger will be addressing in a few moments, but is our sustainable strategy for comprehensive asthma programs and sustainable financing for home-based asthma care. So that has been consistently one of our priorities. There also is some consistency in terms of our commitment to research, whether it was specifically implementation research, coordinating research, or at this point, we're focusing on gaps in research. And the third priority has changed a bit over time, going from data systems to track high-risk children to tribal communities, and now we're more focused on expectations for asthma care. Next slide, please. And so I'm going to focus on the efforts where the NIH and NHLBI have been focused, which essentially the National Institutes of Health, our mission is supporting research to improve the health of Americans. Therefore, I'm very much focused on research in my day-to-day job, and I will focus on our efforts related to research as well as how we go about addressing some of the expectations for asthma care. Next slide, please. So in terms of what have we done and where have we focused our efforts? So this is a program which directly grew out of our coordinated federal action plan, which was, as you may recall, one of the priorities was ensuring that there was comprehensive care for children. Which is to say that there are obviously many things which contribute to children's health outcomes. This program was designed to specifically be community-based. We wanted to ensure that children would be given comprehensive care and that care be integrated. So as you can see, for example, as a medical provider, someone may think that medical care is the most important aspect of it, but in this program, we really have made it emphatically required, actually, that there also be interventions which not only address medical care, but the home environment, the community, and the family's needs. And another big focus of this has been how to ensure that collaborations ensure sustainability. And the issue there is simply that at the NIH, we frequently fund a lot of efforts. People sometimes have success in demonstrating improvements in asthma outcomes. And the issue is, how do those programs get sustained over time? Just because we all recognize that disparities are not something that is going to be eliminated within one grant cycle, which is usually 4 or 5 years. So clearly the programs, if people have effective interventions, we need to ensure that those programs find a way of sustaining themselves. So this is an announcement that we put out in 2017, and it's still ongoing, which is why I'm talking about it today. If we can have the next slide, please. So in terms of we funded 4 groups who are working on these, what we call asthma care implementation programs. One group is working on the Navajo Nation, and that's led by Bruce Bender from National Jewish and Lynn Gerald at the University of Arizona. So they're working on the Navajo Reservation in the Four Corners region, our most westerly group. We also, the other groups are on the East Coast. So we have one program in Providence, Rhode Island, which is led by Beth McQuaid and Daphne Coinas-Mitchell, who are at Brown, looking at a largely Hispanic population in the Providence area. Tyra Bryant-Stevens is working in Philadelphia with a largely Black population of children. And Robin Everhart is working with a mixed minority population in Richmond, Virginia. So each one of these programs actually has a set of interventions that they're assessing in clinical trials. And one of their interventions is to certainly address the home environment, as well as addressing medical care, the community, and family interventions, and integrating that care for children. So these are ongoing studies that we don't know the results from, and probably won't for another 3 years. Next slide, please. In addition, the other question that comes up is the NIH, we support a lot of research, sort of when is it stop being research, and when can we put it into practice? And so the other thing, one of the activities that I've been involved in which we certainly involve our other federal partners in as well, is the National Asthma Education and Prevention Program Coordinating Committee, which is better known for its work on the expert panel report, which is also known by most people as the Asthma Management Guidelines. And so in 2020, at the end of the year, on December 3rd, we published some focused updates to the Asthma Management Guidelines. And so this is one of the ways in which, while the guidelines themselves aren't necessarily focused on any specific population, the expectation is that by setting these evidence-based practices, we hope that care will be improved for all children across the board. Next slide, please. Again, we published this document in 2020. At the bottom of the slide, you can actually see the link to where you can, it was published in a journal, and that's publicly available. We also have it posted on our website, which is on the bottom of this slide. And next, we can go to the next 2 slides relatively quickly, because those are just showing you some of the resources that we have for implementation of the asthma guidelines, both from the point of view of patients and caregivers. In the previous slide had some provider resources. If I can have the next slide. So I just want to summarize sort of the highlights of what I hit here. So the issue that we're trying to address is asthma disparities in children. Why do more children who are minorities have asthma, and why do they actually suffer more from it? We are a group of federal agencies trying to work to eliminate those disparities. In terms of how we've approached the problem, I think we each have areas of our expertise, and we really have partnered to try to leverage and find synergy among the efforts that we've all made. NIH and NHLBI, the efforts that we have are certainly focused around research, and more recently the asthma guidelines. And we hope that research will continue to be done and can be integrated to improve the care for children. So to really summarize, as a partnership of federal agencies, our group collaborates to address disparities, and as a partner, NHLBI has research targeted on interventions to address disparities and disseminates the asthma guidelines based on the available evidence, hoping to improve and eliminate disparities as we move into 2021 and beyond. And with that, I'll turn things to, I think, Tracy. Yes.
Thank you, Michelle. This is Mike from GHHI, and I've got the pleasure of introducing Tracy. who's one of my favorite people that I've worked with over the years. Tracy Washington Enger, Ms. Washington Enger, she's passionate about improving public health through evoking the leadership that resides in all of us. In her work over the last 25 years with the Indoor Environments Division of the EPA, Ms. Washington Enger is dedicated to helping communities control asthma and create safe, healthy homes and schools. Ms. Washington Enger works with communities around the country and internationally, facilitating events to generate action to address a variety of critical health and environmental issues. And I can say as someone who's participated in many of her events, you know when Tracy is facilitating and running an event, and sort of we all sort of benefit from her expertise and energy. She received her BS and MS in journalism from Ohio University in Athens, Ohio, and after graduate school joined the Peace Corps, where she taught English literature and language in Sierra Leone. Additionally, she's an alumni of the Newfield Network International Coaching Program. Tracy?
Hi, Michael. Thank you so much for that introduction. And again, and I want to say I have enjoyed as much as you have partnering with you and with Ruth Ann and everyone at GHHI and the work, the way that you have brought this work into this space and expanded it and made it, provided resources that make it so much more accessible for so many people. And it has just been really powerful. And so thank you for all of the work that you have done and for today, which has just been tremendous. It's been amazing listening to the stories from so many of some of our existing partners right now, as well as some of you whose stories I've been listening to, who you will be partners with us very soon if you are not already. And so thank you so much. So you heard earlier today from my colleague Tracy Mitchell, who's also in the Indoor Environments Division Asthma Program. I am the other Tracy in that program. When we talk about the relationship that we have with the Asthma Disparities Working Group, we're very fortunate to be in leadership around the subcommittee on asthma. And the work that we do at EPA in the Indoor Environments Division has always really been rooted in what we found to really be the place where, when we started doing this work, and in 2004, 2005, what we saw was the power and the strength and the ability of the community-based programs who were doing this work, and the need that they had for the kind of support that we could offer, especially when it came to delivering in-home interventions, and really adding in-home interventions as a part of comprehensive care and making that making that a service for their stakeholders and for their populations. And so with the Asthma Disparities Working Group, what we have seen as we have evolved in this work is both being able to help programs identify and put in place the most effective components for comprehensive delivery of asthma care that is going to see real results and includes an indoor environmental component. But also what we started to see was the importance of making sure that those interventions are sustainably financed. And you saw in what Michelle was saying just now, sort of the trajectory of those priorities within the Asthma Disparities Working Group. And so starting out looking at, building out those program components, just like we were doing within our individual agencies, but then also evolving into a place where we could provide real technical assistance and support around the sustainable financing of those interventions. And so, one of the things that you heard earlier today from Ruth Ann as well is the work that GHHI has been doing on the appropriate metrics and measures for sustainable financing. And that's one of the things that for the Asthma Disparities Working Group, in creating a priority area around this, has been really important for us too, is figuring out what is it that will demonstrate success, and how do we get there, and how do we help community-based programs get there as well, and how do we measure that success. So really appreciating the work that GHHI is doing in providing sort of a level playing field for all of us to tap into as we're addressing these questions about metrics and measures of our success. I'll take the next slide. So one of the things that that you heard also from Michelle is that especially the federal agencies who are collaborating together as the leadership subgroup for the Asthma Disparities Working Group, we all bring our own individual competencies to this work. And we started out as a coordinating committee, this idea of looking across the federal family and seeing who was doing what so we could understand it better and perhaps leverage some of it, but at the very least not be unnecessarily duplicating activities, but really making sure that we were collaborating in the best and most powerful way. Well, when you look at some of the activities that we're all engaged in, and every agency is engaged in activities that are rooted in their individual competencies. But what you will see here is when it comes to sustainable financing of in-home interventions, that has been one of the challenges that has provided us an opportunity to not just coordinate, but actually really collaborate in a way that has made all of our efforts so much better in what we're able to provide to community-based programs across the country. And so we had our friends at HUD who initiated the Sustainable Financing Summits that brought programs from across the country, and our friends at HHS who came in with the medical management component and expertise there, and EPA was invited in with the environmental component, and all together we created something that was so much bigger than the whole, the sum was bigger than our parts. And for us, it really was, I think, the federal government at its best. This is how we should be working all the time. So we were very thrilled to be able to do that. And what we then did at EPA, and if you'll take we'll take a look at the next slide, is so the way that our program kind of works, give me a click, is these are some of the things that we are engaged in. Hosting learning spaces, convening people, bringing them together, and so that what we're doing here virtually, we do as well at EPA, and virtually and in person, hopefully in person again soon, to really get all of the energy and the experience and the backgrounds from all kinds of different stakeholders together, so that we can provide that technical assistance in that space. We also recognize and leverage excellence. And so through our partners like GHHI, as well as our award winners, like you just heard from the Labana program and Susan Stepp, who's one of our previous award winners, and other excellent pockets of community, we bring them together, see what it is that they are doing, mine that information, and then put it back out into the community, if I can get a click there, so that we can synthesize and spread the knowledge. We're positioned to be able to see those pockets of excellence in all of these programs, just like you've been hearing about today, and then put that together in a way that people can access it more quickly, so that they can accelerate their own results, scale up those results, and then spread it to others. And so that is what we have done with the components of the best kinds of programming to have for especially in-home interventions and tailored environmental interventions, but also now for sustainable financing as well. And I can't tell you how gratifying it has been today to hear all of these programs reflecting back to us all of the key drivers that we have been putting out there over the years, like strong champions and strong community ties, and having partnerships, and using the data and the communication to fuel those drivers for success. I've been hearing it over and over and over again today, and it is really exciting to hear. And so we create a home for those kinds of for that kind of knowledge base for you to be able to access through asthmacommunitynetwork.org, as well as through giving voice to those programs. And one of the ways we're doing that, I'll take the next slide, is with our community of practice. And so when HUD convened the Sustainable Financing Summits and invited CDC and HHS and EPA to join them, we had just this tremendous volume of information and sort of advancement in the pursuit of sustainable reimbursement by the participants who were there. And so we wanted to tap into that in a sustainable way. And so we at EPA did one of the things that we do, which is we started to convene those folks and bring them together into what we call the community of practice. And so these were community-based programs who had been present at the Sustainable Financing Summits, who came together to really kind of be a technical support community for one another to advance all kinds of great information. And so if we'll take the next slide, and it also helps keep us honest at EPA in terms of really looking at a metric that we're trying to promote as well. So when we look at, where the success is and and tracking what's going on, you see 12 summits over a 5-year period. Out of that, we started to convene folks, and we see 2 of our programs there that in cities who are receiving MMCO payments. We have 3 states who are receiving state reimbursement in place, and 6 other states who are actively pursuing statewide reimbursement. And we're providing the technical assistance to help them do that. I'll take the next slide. And so we do it in a couple of ways. In one, we bring people together. If we could just go back one for me quickly, we bring people together, the community of practice together, so that they can chew on some of the thornier issues about reimbursement. They've talked about everything from getting CHWs, community health workers, reimbursed, to most recently the conversation about how they are pivoting for asthma home visits in the face of COVID. And then we take that information and we turn it forward facing out, so that other programs who are not in the community of practice but are along that continuum towards reimbursement can benefit from their knowledge. And so we have webinars. The last webinar, we had 400 people with our community of practice presenting what they have learned. And then we continue to then go back and delve into the next issue. Right now, we're looking at alternative payment models for CHWs and for home visits and for environmental mitigation. I'll take the next slide. So some of the top end learnings that we've done, and I'm going to go a little quickly here, but some of the top end things that we've seen. One is, what you've been hearing all day today, that we know that communities with these established connections across the healthcare, housing, and environmental sectors have been the most successful at pivoting, especially during COVID, right? And continuing to provide in-home interventions. We also know that while it has been a challenge during this time to provide those in-home interventions, virtual platforms and innovations continue to arise, right, to surface. And also that we are seeing that with the right pitch, that healthcare payers are continuing to recognize and reimburse these interventions. I'll take the next slide. But some of the most important things that we have heard from our community of practice have to do, again, with what you've been hearing. And I think one of the most important ones is this recognition around the fact that the home is the root of where the powerful health care is taking place. And so many of our partners are coming in and recognizing that as well. And when we look at the social determinants of health, it's not just us. We are not alone in the recognition of the importance of social determinants of health in how it drives healthcare and how it drives value. So this is really a moment for us to be capitalizing there. I'll take the next and last slide. And then I think some of the other key takeaways, we know that the reimbursements are happening, but as you heard earlier, they are not happening. They are underfunded in many cases. And so at EPA and within the Asthma Disparities Working Group, we're looking at how we also are providing technical assistance to the payer side as well, so that they are right for you when you show up with your fabulous community-based program that is getting all of these results, so that they have the ears to be able to listen and for all of the different vehicles and different routes to funding, that we're talking to those funders on that end as well. And just finally, I will close here. You were just hearing about this from Susan Steve with the question that came up about the decline in utilization that we are seeing, and where and what's behind that. So this is one of the places where having something like the Asthma Disparities Working Group is so great, because we are also looking at what that utilization means, that reduction in utilization means, how it ties in to kids not being in school, and that, and looking at the symptom threshold. It doesn't mean that that the home isn't still an important place for us to be focusing our activities just because utilization has dropped, but what does it mean in terms of the school setting combined with the home setting, and what does that, and what data do we need to produce to help us tell the story of 2020? And so we have also, as you saw, we're looking at the evidence gaps, and we're looking at expectations within the Asthma Disparities Working Group. So all of these things really tie in together. So that's the story that I've got right now around the work that EPA is doing and how it fits into the larger story of the Asthma Disparities Working Group. Thank you for your time, and thank you so much for continuing to be with us this afternoon. And thanks again to GHHI. And I will turn it back over for you for the introduction for our final speaker from the Asthma Disparities Working Group.
Thank you, Tracy. And yes, and we'll go to questions after hearing from Peter, but another one of my favorite partners that we work with, and I feel like has been on this journey with us for a number of years around sort of reimbursements, Peter Ashley from HUD. Peter directs the Policy and Standards Division within HUD's Office of Lead Hazard Control and Helping Homes. The division manages the award of grants and contracts for research on residential hazard assessment and control methods, contributes to policy development, and develops and implements special initiatives. He received a Doctor of Public Health degree from Johns Hopkins School of Public Health and a Master's of Public Health from the University of Michigan. Peter?
Thanks very much, Mike. Yeah, I think you had to say that you like working with me after saying that about Tracy, it's mutual. We really enjoy working with you and your colleagues at GHHI. And it's great to hear about all the good work that's being done around the country today. Next, please, next slide. Looks like we've got a little bit of a glitch in the slide.
Maybe a slight delay. So
yeah, I can, okay. So these are the topics I want to address today. Talk a little bit about some of the research we're funding through our technical studies, Healthy Homes Technical Studies grants. One recent effort that we've engaged in to promote health insurer reimbursement for lead and asthma home assessments and interventions. And then I want to get into some of the things we're doing to improve the quality of HUD housing with respect to making them more asthma friendly. And then finally, what everybody wants to hear, sources of funding from HUD, from my office, that could be used to promote home asthma intervention programs. Next, please. So just quickly wanted to, these are studies that are still ongoing, it shows the year that they were funded. Because of COVID, not surprising, there's been some delays, and a lot of our grantees will need extensions for their research. It's hard enough to do field research when things are normal. You can see that a couple of these studies are focusing on asthma in adults. We highlighted that in our notice of funding availability because we knew there needed to be more research in that area. The study at Baylor is being done in public housing, so multifamily housing, which makes it a little bit more unique. They're also using some novel methods to assess exposures that could trigger asthma in the homes. And then Illinois Institute of Technology is actually looking at working with a local veterans hospital to look at the efficacy of portable HEPA filters to improve IAQ and health for veterans with COPD. We've done, I think this is the second study we've supported that is looking at COPD as an endpoint. It's one thing I wanted to mention that is, I guess, linked to what Dr. Freemer was talking about in terms of the recent guidelines update, is that they did fund a critical review of research on home allergen control. This is NIH that supported this, and a paper was published in 2018. It conducted a critical review of the evidence, and it's not as good as we'd like it to be. They concluded that there's insufficient evidence demonstrating the efficacy of most single or multi-component strategies on important asthma outcomes. We could talk a long time about why this is, but it's challenging research to do and to get definitive results. You need a large sample, a very strong design. They did conclude that the strongest evidence was for multi-component interventions that include the use of HEPA vacuums or pest control as one of the components. But that's maybe something for another webinar. Next, please. So I just wanted to mention that the Healthy Homes Technical Studies grants, we offer those every year, about 3 to 4 million in funding per year. So if you're interested, please take a look at that. But we do expect applicants that are doing research on asthma to address some of the weaknesses identified in that NIH-supported review. So this is something we supported recently. We provided a small contract to the National Council of State Legislatures, they're located in Denver, to provide content on their website targeting state legislators and their staff on the issue we've been talking about today, on getting Medicaid and MCOs involved in reimbursing, covering the costs of some of these home-based services. We were initially focused on lead when we approached them, and then we realized, well, we really needed to include asthma. And they already had some senior fall prevention content, so we also supported updating that as well. Next, please. And I wanted to talk today, as I mentioned, about the things we're doing internally, working with HUD program offices to improve the quality of HUD-assisted housing. We're kind of a burr in the saddle sometimes of the HUD programs, advocating for more attention to the quality of housing in terms of health and safety hazards, and providing technical assistance. A lot of you probably know about HUD's initiative to reduce smoking in HUD-assisted housing. This led to an actual regulation that has prohibited tobacco smoking in public housing. And that should have a benefit, of course, on people with asthma. And we've worked with NIH, well, actually CDC, the branch that, the office that's involved in the national surveys, to link HUD data on HUD-assisted residents with this national survey data, NHANES and NHIS. So over time, we should be able to see if this smoke-free requirement in public housing, results in improvements in asthma. I mean, you can't say it's causative in this type of study, but it provides some evidence for that. Also integrated pest management. We've been funding technical assistance through Cornell University's Northeastern IPM Center. That's a stubborn issue, partly because of, I guess, systems type of problems, type of contracting that HUD-assisted housing providers do, and hiring low-bid pest control contractors who when you look at what they're being paid, just don't have enough time to do it right. So part of this is really educating both HUD management and then the housing management out in the field. And then there's an effort to improve HUD's housing inspection standards. That's an ongoing effort. Watch the different listservs because there are opportunities for you to comment on draft standards when these are developed. Next, please. So, hey, this is the big one for you folks. I mentioned the tech studies funding for research. Our lead hazard control grantees also receive what we call Healthy Home Supplemental funding. So last year, it might have been 600,000 to 400,000 was the range. But these can be used to address non-lead health and safety issues in the home. So the homes have to be brought in based on the presence of a lead hazard. But oftentimes, this is low-income housing. It's a high-risk population for asthma. So they will end up seeing quite a few residents with asthma and can use these funds to address asthma triggers. A new one starting last year, a new grant program, and that's this one. Congress gave us this funding, and they said, hey, we want you to put out $5 million in funding to 5 communities. So we divided 5 by 5, and we got 1 million to be awarded to each applicant that's successful. And the purpose of this is to facilitate delivery of coordinated interventions by HUDs, lead hazard control grantees, and the DOE's, Department of Energy's Weatherization Assistance Program. In this case, they're really sub-grantees because the grants go to the states. And this is a model, of course, that GHHI has been promoting for years. I mean, it makes all kinds of sense. There are some barriers in terms of income eligibility, differences between the programs, but those can be overcome. But you're really providing your client with a lot of you know this. I saw mention of this in your presentations earlier today, but you're really providing them with added benefits by combining the programs and including energy efficiency, and both target this a similar program. So it just makes a lot of sense. We're also working with DOE to address that income eligibility issue. So hopefully we'll make some progress on that. And then this is the big one for this year. We offer these Healthy Homes Production Grants, similar model as our lead hazard control grants. But in the case here, grantees are expected to identify multiple health and safety hazards in a home, again, targeting low income housing, and then to address those multiple hazards. We offer this when we have sufficient funds. This year we do. Awards expected to be $1 to $2 million. So those of you who are implementing, home asthma programs, you could either be a sub-grantee on one of these, or you could come in for an award. But you just have to realize that these are meant to address multiple hazards after a comprehensive home assessment. Next, please. Okay, that's it. So thank you for your attention after a long day, and great to hear about all the good work that's going on. I did. It was good to see some of the positive outcomes of some of the summits that we've helped support over the years around the country. Partnering with EPA and CDC especially. So that's gratifying to see, and keep up the important and good work. Thanks.
Thanks, Peter. And we're running a little bit short on time, so I have time for a couple of questions. One immediate question for you around that. a new grant opportunity. Is there a timeline for when that NOFA will be released?
That's always challenging. I believe it's in departmental clearance now. Let's say May. I think June probably would be a good target for that.
Great. Thank you for that. And then there's a question around, I think for you, Tracy, but I think it also may apply to Michelle as well, around sort of climate change now with this current administration and so an emphasis put on climate change. Is there any sort of ways in which sort of impacting ways to mitigate climate change and those efforts would also sort of be sort of related to sort of the efforts around addressing sort of environmental conditions and asthma?
Yeah, I was looking at that question, and Michael Kent, you are right. It is a new day, especially at EPA in terms of the way I think that we're going to be approaching climate change and reapproaching climate change. And there is already a call kind of across the agency for upping our game and integrating those messages. And so I think it's a really good opportunity for us to be looking, like you said, with, especially addressing social determinants of health, seeing the, some of the disparate impacts of climate change on different communities and being able to weave that into the work that we're doing with asthma. I think that there are lots of opportunities there. So we are, believe you me, I've got my ear to the ground on that, definitely.
Thanks, Tracy. I don't know if you had anything to add, Michelle, or anything around research that may be upcoming.
There are actually, well, I can't say anything about funding announcements. We actually can't, I can't say anything about those until they're actually made public to everyone. But I will say that within the President's Task Force, the parent committee, there certainly was already an emphasis in a group working on climate change, and certainly the impacts on asthma have been appreciated, as well as the other area that's of some interest are natural disasters in general, things like wildfires, and how that obviously is another environmental exposure that would impact and potentially impact children with asthma more than others. So those are areas that agencies are working on. As far as specific funding announcements, those are all, at least for NIH, those are centrally posted. I'm happy to give anybody who wants to information on where you can find out about those.
Thank you, Michelle, and Tracy and Peter for all that great information. And now I'd like to turn it back over to our President and CEO, Ruth Ann.
Michael, thank you very much. And what a panel and what a great day this has been. Every panelist I learned something from, and I think I sometimes think I've been around a long time and can't learn more, and I learned a ton today. So I hope each of you did too. And I just want to thank all of our panelists and partners here. And on a day where we're seeing hundreds of millions and billions of dollars be announced to help us move forward in the United States, including money that's going to go into housing improvements. This was incredibly useful information. In 2015, GHHI, along with Le Bonheur Hospital, were the two awardees to the EPA's Excellence in Leadership, Asthma Leadership Awards. I think today I saw lots of potential winners out there, and would encourage every program that is presented here today to think about applying for or being nominated for EPA's focus on leadership in asthma, because I certainly saw that happening here. I know we also, I think Daniela may have some slides for us on other links and connections that we will share with you from our technical assistance and trainings and metrics work. Our team is available to help provide technical assistance and support to help you think further about the critical issues around the link between asthma and housing, and how we use in-home education to improve outcomes for all of us. And I think the technical studies that HUD is doing are so important to think about in terms of applications there. I want to thank our wonderful team, not only the policy and innovation team that worked on the EPA grant that you know, but the large team at GHHI who has supported this work and all of our work. I especially want to thank Daniela Chambers, who's kept us all online and going today, Brendan Brown, Trent Van Alphen, Kevin Chan, Kirsten Sweeney, and Michael McKnight amongst the team on the EPA work. And of course, we thank the twin Tracys of EPA for the funding for this program, our partners at HUD and NIH, and the many partners that you see here. And I think I did, and I want, if you didn't hear me, definitely give a shout out to Daniela Chambers on her work, not only on production for today, but for her work with our sites. And just amazing, amazing work that we hope to continue as we expand and move forward on health-based housing work. Our slides will be available on our website, as well as a recording of this day and activities. And please visit our website and let us know if there are things that you don't see there that we can add. But most of all, I want to thank each of you for what you do to endeavor to improve the quality of life for every American, especially our under-resourced communities, our communities of color, as we really try to bring and rate things forward in a just society to improve health, economic, and social outcomes. I know that we're deeply dedicated to this mission, as are you, and we are honored to work with each of you. So I would just really appreciate the opportunity to get your feedback in the survey that we're going to send you to continue to hear on the progress you're having in your programs, and to remember that we are here to be your thought partners, your cheerleaders, your problem solvers with you. We are big believers in collaboratives, and we're big believers in you. So thank you so much for joining us today. Take a break from a long day of Zoom, which has been a very good day. And I thank each of you. Thank you.
Thank you, everyone. Just as a reminder, as we wrap up, all the links that Ruth Ann just mentioned are being copy and pasted into the chat. So you should have that available to you. We'll also be putting these up on our website, and we'll notify you via email when everything is up and available. And we do have our survey if you want to take it now. We know you've been on with us for all day, but we appreciate it. The survey here is some feedback on today's event, as well as what your needs are for your asthma program. So Allison Magnusock just put it in the chat for you. If you have any questions, let us know. We will also be sharing this out via email, so keep an eye out for a follow-up email from us. Thank you so much. Have a great rest of your afternoon and a great rest of your day. Thank you.
Hi, all. For anybody who's still listening, we did repost a survey link. It should work now, but if it doesn't work for you, we'll be emailing you the survey link directly to your email as a follow-up to today. Thank you.